request the President, Dr. P. Ganesh, to come around and give his welcome address, please.
Good evening, everybody. It gives me great pleasure in welcoming you all to our monthly CME program. And we really hope that more people join on time and then we could start in time. And a couple of weeks ago we had a ECME program conducted by Thoothukudi Medical College. It was a lovely program. I really hope that more postgraduates join, because this is only for you. And you would be encouraging your colleagues to probably go on stage, because 2 wonderful cases were presented. Hopefully only about 30 logged in, out of which 10 were consultants, so only 20 PGs logged in. So I really request all of you to log in. It is on par with any PG course. It gives you up to date. And then there were 2 wonderful case presentations and a beautiful lecture by Dr. K.T. Shenoy on even if you take your Google and take 100 review articles, the amount of information he gave in that half an hour was awesome. So I think it benefits all of you. I honestly request all of you to join this ECME program in good numbers. It really helps and encourages your postgraduate colleagues. We start off with the program today, Postgraduate Clinic. We see the panelists are already there. Rajashekaran, yet to come. Manjunath, Sriram Sujan, yes. Sneha, okay. Kishore Ravi, you're there. Okay, now I invite the chairperson, Dr. Joseph Jen Singh Babu, to take over, invite the moderator and start the proceedings. Thank you all.
Team of panelists and postgraduate panelists, and I request Dr. B.J. Gokul, who is going to moderate the session. He is a senior consultant, Medindia Hospital, Chennai. Over to Dr. Gokul.
Respected teachers, my dear colleagues and friends, first of all, let me thank Dr. Paramanayagam and the organizing team of TNISG for this opportunity. It is commendable that we have come up with a new program for the postgraduates where we'll be learning together with them as moderators. So today we have taken up one topic, upper GI bleed management. I'll be covering only the non-variceal bleed. So before going to the case capsule, I'm going to discuss only one case. Regarding the definition, upper GI bleed is bleeding originating from sites in the esophagus, stomach and duodenum. Basically from the source is above the ligament of Treitz. It could be acute, occult or obscure GI bleed. The presentation, as you all aware, could be hematemesis, melena or hematochezia. The incidence is between 50 and 150 per 1 lakh persons per year. Predominantly it occurs in elderly population and carries significant mortality of up to 10%. With regards to the etiology, the non-variceal causes would not only include peptic ulcer disease but also gastroduodenitis, esophagitis and Cameroon ulcers, and varices not only esophageal gastric but also portal hypertensive gastropathy. Other causes are less common, namely the Mallory-Weiss tear, vascular etiologies, neoplasms, etc. Now coming to the case, a 62-year-old male, a known case of hypertension, diabetes and CKD, had been symptomatic for 3 days. He came with complaints of passing black-colored stools 3 times per day. There was no hematemesis, abdominal pain, abdominal distension, altered sensorium, dark urine or reduced urine output. So, question to the panel. So maybe you can begin with, and then for the next question you can take over. So all of the following are true regarding bleeding source from the upper GI tract as compared to lower GI tract, except history of melena, melenic stool on examination, blood or coffee ground detected on nasogastric lavage, ratio of blood urea nitrogen creat less than 30, and none of the above.
Sir, it is option 4, sir. Ratio of bun by creatinine is less than 13. Usually in upper GI bleed, bun by creatinine ratio is more than 30, sir.
Good. So, with regards to the clue, whether the source could be possible upper GI source, this is the likelihood ratio which they have evaluated. When there is history of melena, when there is melenic stool on examination, blood or coffee grounds in nasogastric lavage, and the ratio of bun creatinine more than 30. So, all these are possible indicators, and it becomes less likely when there is presence of blood clots in stool. And similarly, factors associated with severe bleeding would include red blood detected on nasogastric lavage, presence of tachycardia, and hemoglobin less than 8 grams. Past history is very important because it's interesting to note that a patient with a past history of UGA bleed subsequently bleed from the same source 60% of the time. And what are the clues that we can get from the history? For peptic ulcer disease, any past history of or recent H. pylori infection, use of NSAIDs or smoking. For malignancy, any smoking, alcohol use or H. pylori infection. For variceal bleed, history of alcohol abuse or presence of CLD. And other rare problems like iotentric fistula, angiodysplasia in a patient with renal disease, and marginal ulcers or stomal ulcers in patients who have had a previous GJ. Now, question to the panel. You are all aware of the medications which can possibly trigger UGI bleed. What medications apart from antithrombotics and NSAIDs are associated with increased risk of GI bleeding, not necessarily causative? Is it SSRI? Is it SNRI? Is it calcium channel blocker, oral iron, or all of the above?
Oral iron, sir.
Oral?
Iron.
Oral iron, okay. So, let us see the medications which can possibly trigger GI bleed. You are all aware of the NSAIDs, anticoagulants, antiplatelets, and pill esophagitis. Bisphosphonates, aspirin, potassium, all this can cause pill esophagitis and cause bleed. There are some drugs which can be associated with GI bleed, which include SSRI, calcium channel blockers, and other 2 drugs also. I'll come to the thing next slide. Black stools can be associated with intake of bismuth, charcoal, licorice, and iron. The mechanism of bleed in SSRI or SNRI is that it inhibits serotonin reuptake and thereby it disrupts platelet aggregation and impairs hemostasis. By some mechanism, it also increases gastric acid secretion. Calcium channel blockers has antiplatelet effects. Oral iron undergoes oxidation and generates free radicals and can damage the mucosa. The answer is all of the drugs can be associated with GI bleed. Coming to physical examination, our patient, he was alert, he had pallor, no icterus, vitals were stable. Examination, no abnormal findings could be identified. Examination in general for a patient who comes with upper GI bleed, assessment of hemodynamic stability is very important. Abdomen examination with regards to not only organomically any rebound tenderness or godding, examination of stool color, any stigmata of chronic liver disease to differentiate variceal from non-variceal. You are all aware of these facts. Assessment of blood loss is very important. You see that the blood loss in volume as well as in percentage has been given, and as you see that the vital parameters gets abnormal when there is blood loss. Tachycardia is the earliest one to happen. What is the second sign that is elucidated when the patient has got ongoing blood loss? One is tachycardia, as you all aware. Postural hypotension. Yeah.
That's all. Postural hypertension.
Okay. Yes. Before postural hypertension, actually, when we measure the blood pressure, the pulse pressure gets narrowed. That happens a little earlier compared to a drop in blood pressure, actually. This is because of increase in peripheral vascular resistance. The diastolic BP actually goes up, and that narrows the pulse pressure. You're all aware of the other facts like capillary refill, respiratory rate, reduction in urine output, and altered metal status. In our patient, the hemoglobin at the time of presentation 4.8, MCV 76, urea creatinine were elevated. This is a known patient with CKD. Blood urea nitrogen 64, ratio 29, albumin 3.1, LFT normal, electrolytes mild hypokalemia. Now question to the panel. Which of the following is false regarding hemoglobin assessment in a patient who comes with upper GI bleed? Number 1, initial hemoglobin levels may be normal or even elevated. Number 2, administration of IV fluids and drawing of interstitial fluid causes hemodilution. Number 3, true extent of blood loss is identified after 8 to 12 hours. So we need to recheck the hemoglobin after 8 hours or earlier if there is ongoing bleed. Low MCV means there has been a chronic bleeding. None of the above.
None of the above, sir.
Good. An acute bleeding doesn't alter the MCV. So this patient with low MCV means that the patient had been having a chronic bleeding on top of which this acute episode has happened. The initial hemoglobin can be fallacious. We need to recheck every 2 to 8 hours. Because there is a dilution because of the IV fluids which we administer and also because of the drawing in of the interstitial fluid. The ratio of bun creatinine is typically more than 30. We need to check the LFT's coagulation profile and serial ECGs and cardiac enzyme, especially in older patients who come with chest pain and known history of CAD. Ultrasound abdomen, bilaterally small size kidneys and with increased cortical echoes. These are the common scoring systems which we use in practice. The GBS or the Glasgow Blatchford's bleeding score, pre-endoscopic and complete Rockall score and AIM-65. Now question to the panel. Which is false regarding the use of scoring systems in a patient who comes with GI bleeding? Low risk patient can be safely managed in an OP setting, number 1. Number 2, it allows healthcare providers to prioritize resources. 3, it guides decision about the timing and the type of intervention, whether we need to do endoscopy, surgery or transfusion, improve patient outcomes and reduce mortality, decrease healthcare costs.
4, sir. Improves patient outcome and reduces
Mortality, right? That's what we think, no? But then I have not given one more option here, which is the 6th option. None of the above. So let me come to that later. You're all aware about the GBS or the Glasgow Blatchford score, which takes into account 8 parameters, 2 symptoms, syncope and melena, 2 organ system involvement, hepatic, cardiac, 2 vital parameters, pulse rate, BP, and 2 lab tests, hemoglobin and BUN. Our patient, the score was 11. Any score more than 0 is a high risk. That's what the guidelines say. And that patient need to undergo a medical intervention, likely either transfusion, endoscopy or surgery. And score more than 6 is associated with more than 50% risk of needing intervention. AIM-65 score is one score which takes into account the albumin value, INR, altered mental status, systolic BP less than 90, age more than 65. With increasing scores, as you see on the right side, there is increasing in hospital mortality rate. Our patient, the score was 0, which is equivalent to 0.3% in hospital mortality. The AIM-65 score is superior to the GBS in predicting mortality, whereas GBS is superior in predicting the need for intervention, like transfusion or endoscopy or surgery. We managed the patient by giving a PRBC transfusion. The nasogastric tube aspiration did not reveal any altered or fresh blood, and IV PPI was started. The management of a patient with GI bleed includes securing 2 intravenous catheters, peripheral catheters, 18 gauge or larger, IV fluids 500 ml of normal saline or ringer lactate over 30 minutes. Of course, the rate of fluid should be guided by the pace of bleeding, and those at risk of fluid overload should requires intensive monitoring, and temporary inotropic support may be required. Coming to nasogastric lavage, so how many of you in the audience would put a nasogastric tube when the patient comes with upper GI bleed? Can I have a show of hands? Okay, so nasogastric lavage is associated with early time to endoscopy, and because any bloody aspirates could be associated with high risk lesions, it removes particulate matter and facilitates endoscopy and confirms an upper GI source of bleeding. But then the recommendations from various guidelines, American not recommended for routine use, European do not strongly advocate. British do not explicitly mandate nasogastric tube placement. So it is not routinely recommended procedure. Now question to the panel. Regarding the pre-endoscopic administration of erythromycin, because most of the guidelines say about erythromycin, though we don't routinely use that. All are true regarding the use of pre-endoscopic administration of erythromycin, except it reduces the need for repeat endoscopy or hospital stay, reduces the risk of further bleeding. The dose is 250 milligrams over 30 minutes and do endoscopy 30 minutes later. Do a baseline ECG electrolytes and ask about the drug history. So which of the thing is false?
Reduces the risk of further bleeding.
Good. So it doesn't reduce the risk of further bleeding. Other things are correct. With regards to transfusing packed cells in a patient who comes with UGI bleed, the threshold is 7 grams. That's what the guidelines say. But in certain indication, we use a threshold of 8 grams. So what are the, a threshold of 8 grams is used in all of the following indication except, number 1, exsanguinating hemorrhage with hypotension. Number 2, acute coronary syndrome. Number 3, pre-existing cardiovascular disease. 4, chronic liver disease.
Except in chronic liver disease, sir.
Yeah, very simple questions. It is CLD. Because more you transfuse, then there is higher risk of increasing in portal pressure and further bleed.
Yes.
So in a patient who comes with active bleeding where there is hypovolemia, the transfusion is not to be guided by hemoglobin, but rather than the hemodynamic parameters. So regarding, we need to look into the pace of bleeding and also whether you are able to stop the bleeding. So all this would actually guide whether how much you want to transfuse. Whereas in a hemodynamically stable patient, a restrictive transfusion strategy is advised, where you transfuse when the hemoglobin is less than 7. The advantages of restrictive strategy is that it carries lower mortality, less further bleeding, fewer transfusion reactions and less cardiac complications. We don't routinely transfuse platelets unless there is life-threatening bleeding and a very low platelet count of less than 50. In cirrhosis, there are no recommendations to correct an elevated INR because we now go by thromboelastography and ROTEM, because INR is not a reliable marker. In those patients who are on vitamin K antagonists like warfarin or acinocumarol, we generally divide them into a low risk bleeding and high risk bleeding. When the patient comes with bleed, when the patient is already on vitamin K antagonist, endoscopy is found to be safe when the INR is less than 2.5. There is no need to correct it. When there is low risk bleed, we generally withhold drug, slow reversal with vitamin K IV, which normalizes INR gradually in 3 days. We generally routinely do not transfuse PCC because there is a risk of thrombosis. When there is a high risk bleed, we again discontinue vitamin K antagonist, give vitamin K, and we give PCC and check INR 30 minutes later, and if it is still more than 1.5, we give additional PCC. If that is not available, we give FFP. It is very important to restart these drugs within 7 days because there is a high risk of thrombosis. What about bleeding in a patient who is on antiplatelets? That is, we need to strike a balance between thrombotic events and avoiding bleeding. So if the aspirin has been started for primary prevention, it is generally not restarted. If it has been started for secondary prevention, you restart in 3 days, but not later than 7 days. The patient is on dual antiplatelet, you stop both, restart aspirin first in 3 days, and then restart clopidogrel in 3 to 7 days. This again holds good when the patient is at high risk of thrombosis, when the patient has had a recent PCI, acute coronary syndrome or mechanical valves. Now when the patient is on direct anticoagulants, which has been used more frequently nowadays, we withhold the drug, give a gastric lavage if the patient has ingested it within 3 hours, administer PCC or recombinant factor 7A. If specific reversal agent is available, then we can use it. If for dabigatran, dialysis has been tried, found to be helpful to reduce it. Now coming to the question regarding the use of PPI before endoscopy. So how many think that PPI should be started before endoscopy? Among the panel, can I have a show of hands? How many of you would start PPI? Okay. Now what the guideline says that they have used in one study IV omeprazole followed by 8 milligrams per hour, 80 milligram bolus. There is reduced endoscopic requirement for hemostatic treatment, but there is no benefit with regards to rebleeding, mortality or the need for surgery. What does the guideline say? European guidelines says it is recommended, British not recommended, American recommendation could not be reached. So it is up to us to decide whether we need to give, but it is justifiably, we can start them because it reduces the need for endoscopic hemostatic treatment. Coming to timing of endoscopy, endoscopy is generally done within 24 hours of symptom onset, but not admission. That is very important. Patient would have started bleeding the previous evening. He comes to us the next day morning, so we need to calculate that into account. When there are low risk clinical features like hemodynamically stable patient, no severe comorbid conditions, you can do an early endoscopy within 6 hours so that you can identify things like clean ulcer where you can plan for discharge. That helps to reduce the hospital stay and cost. But in general, when the patient is hemodynamically not stable with multiple comorbid conditions, you need to stabilize the patient first before doing an endoscopy. Our patient underwent endoscopy. There was active bleeding. We couldn't initially identify where actually the patient was bleeding from. Then finally, we, after repeated flushing, we identified that there was a non-bleeding visible vessel. Initially, it was oozing, but by the time we did it, after flushing, we identified this vessel at D1, D2 junction with, you are able to see the ulcer beneath that. There is also an ulcer there. Now coming to Roll Call scoring system, we have this pre-endoscopic and complete thing where we take into account these parameters: age, presence of shock and comorbid conditions, and after endoscopy, what is the diagnosis and is there any SRH? The maximum score pre-endoscopy is 7, complete is 11. In our patient, the score was 7, and which indicates 43% rebleeding risk and 27% mortality. You are aware of this Forest classification. Typically, endotherapy is used when there is 1A, 1B or 2A. These are the methods of endoscopic hemostasis. You are aware of the mechanical methods, injection methods, what drugs we used. Thermal, we have contact and non-contact, and we have hemostatic sprays. Tools for endoscopic hemostasis, very important to have a flushing pump so that we are able to see the site of bleed better, apart from other accessories which you are all aware, the heater probe, gold probe, co-grasper, hemoclip, APCs. In general, the guidelines advocate combination therapy as compared to monotherapy, because we can divide this into two things. When there is active bleeding, 1A, 1B, it is very important we use a combination therapy. We inject and then use either a thermal or a mechanical method, because this is found to reduce rebleeding. Monotherapy is still a choice in a patient who has got a non-bleeding visible vessel. There is no active bleeding. We can do a thermal method or a mechanical method as an isolated procedure without combining. But in general, the guidelines say a combination therapy is better. So this patient, we saw that lesion. So we injected adrenaline in all 4 quadrants. Following that, we used gold probe coaptive coagulation. There was still a minimal bleeding after coagulation, and we finally used a clip as well. Though either one method is good enough. Some studies they have combined both. Now question to the panel. All of the following are true regarding endotherapy except Forest 1 and 2A requires endotherapy, number 1. Number 2, if there is adherent clot, guillotine the clot provided IR or surgical backup is available. Number 3, adrenaline injection should be followed by either a thermal method or mechanical method. 4, soft monopolar electrocoagulation is not an accepted treatment modality.
Sir, third one, sir.
Third one, adrenaline should be followed by either a thermal method or a clip.
Can use it before thermal method. For a better visualization, it will help, sir. So
Yes. So that is true or false?
Sorry, sir. That is true, sir. Fourth is the false.
Yes. Fourth is the false, because we use coagrasper, which is a monopolar electrocoagulation method. Our patient, he was continued on PPI twice daily for 3 days. After IV PPI for 3 days, after endotherapy, hemoglobin improved, iron and erythropoietin were administered. Now question to the panel regarding post-endotherapy PPI use. What is the minimum PPI dose per day which they have used in various studies after endotherapy? Is it 40, is it 80 or it is 160?
80 mg, sir.
Yes, 80 mg is the correct answer. Will you use an intermittent or a continuous IV PPI infusion?
Intermittent or continuous are shown to be effective. Normally, infusion continue for 72 hours.
Yes, they compared actually, and the systematic review and meta-analysis shows that either of intermittent or continuous PPI, both are actually, there is no difference actually. Can a high dose oral PPI be given instead of IV PPI after endotherapy? Maybe you can also take up the question. Can you use high dose oral PPI? High dose meaning 80 milligrams, oral PPI like 40 mg twice daily instead of IV twice daily after endotherapy?
Yes, sir.
Yes or no?
Yes, sir.
Yes, we can use, because studies have shown that if the patient can take orally, IV PPI twice daily or oral PPI doesn't make any difference. We can also give 80 milligram bolus followed by intermittent IV or oral PPI as an alternative. But in general, there is a high risk feature. It is better to go for IV infusion following bolus because we have evidence to support that. It's after endoscopy. Now this is a study which was published in gastroenterology. This study came from Thailand where they compared vonoprazan with PPI. Following endotherapy, patient was randomized to vonoprazan group versus PPI group. No difference. So this is a good alternative. Now question to the panel. Will you routinely treat for H. pylori after endotherapy?
If it is proven, I will treat.
Good. You test and treat only if it is positive. Suppose it is negative. Is there any indication to retest for H. pylori later?
In acute bleeding, there can be a false negative rapid urease test. So I will retest for H. pylori and treat later.
Yes, the recommendations is yes, we need to retest at a later date if the initial test is negative. It is very important that we confirm eradication 4 weeks later completing H. pylori treatment, especially when the patient is going to be on long-term NSAIDs. Now, when the patient has gets an endotherapy and there is rebleeding, now the options available to us are repeat endoscopy, intervention procedures, radiology procedures and surgery. Now, which of the following regarding rebleeding is false? Repeat endoscopy is advised, number 1. Number 2, if the thermal method was used earlier, choose an alternative method for the second session. Number 3, surgery is associated with lower complications than repeat endoscopy. 4, if the initial presentation was hypotension and ulcer size had been more than 2 cm, go for intervention IR procedure or surgery than a repeat endoscopy. Which of the option is false?
Sir, 3, sir.
You feel that surgery is associated with higher complications
Sir,
compared to a repeat endoscopy. Is that it?
No, sir. 4th one. Is
4th one, initial presentation hypotension, better to, okay. So, studies have shown that a repeat endoscopy is better compared to a radiological procedure or surgery because it is successful in a majority of patients. And if the thermal method was used earlier, go for an alternative method like a mechanical method. Otherwise, there is a high risk of perforation. There is also one more option available to us in the form of OTSA clips if the patient fails endotherapy. The answer to this question is surgery is associated with lower complications. No, it is associated with higher complications. Other options are correct. Now, when the patient has a second time endoscopy for rebleeding, that also fails. So, there is a failure of endoscopic therapy. Now, at this juncture, we have two options, either IR procedure or surgery. Which of the following is false? Number 1, further bleeding is more common with IR procedure than surgery. Major complications are less common in IR procedure. Local expertise and availability of procedure should be taken into account. Mortality is higher with IR compared to surgery. Which of the following is False.
Four, sir. Mortality is higher.
4.
For
Mortality is higher with IR compared to
even.
surgery.
or one.
Okay, so let us see the evidence. We have two options. The failure of endoscopic therapy is variably defined, either persistent bleeding or a recurrent bleeding after endotherapy. This IR procedure has got shorter length of hospital stay, fewer complications as compared to surgery, but the caveat is there is slightly higher risk of rebleeding compared to surgery. But ultimately the choice depends on the available expertise. So the answer to this question would be, number 1, further bleeding is more common with TAE is correct. Major complications are less common in transarterial is correct. Local expertise and availability should be taken into account. Mortality is higher with TAE compared to surgery is false. Mortality is higher with surgery. So to summarize, initial assessment and resuscitation is very important. You all know the ABC of emergency management. Prioritize airway protection. The patient when is having massive bleeding or there is altered mental status. Stabilize the patient hemodynamically. Secure IV access, 2 lines, crystalloids preferred. PRBC transfusion. Monitor vitals and urine output. Risk stratification like GBS is very important to guide decision regarding the timing of intervention and also to calculate the mortality. IV PPI before endoscopy can be given. Avoid over transfusion because restrictive strategy carries less mortality and less cardiac complications and less reactions. Early endoscopy within 24 hours is advised. If the patient has got a low risk bleeding, you can do endoscopy within 6 hours so that you can discharge the patient. Hemodynamically unstable patient, don't forget to resuscitate first because unresuscitated endoscopy carries higher mortality. Dual therapy is always advised, especially when the patient has got a active bleeding. Monotherapy could be still considered when the patient has got non-bleeding visible vessel. Continue PPI infusion or as intermittent doses for at least 3 days, especially in high-risk bleed. Plan for secondary prophylaxis. For non-variceal bleed, test and treat for H. pylori, stop NSAIDs and anticoagulants, but always resume those drugs as early as possible because studies have shown higher risk of thrombotic events and mortality compared to higher risk of bleeding. Multidisciplinary approach is very important. We always work together with surgeons and IR specialists so that patient gets the benefit. Thank you very much.
Thank you, Dr. Goval. I think you have listed all the guidelines points, point by point. Really excellent. Is there any questions from panel?
Thank you, sir.
And I should also appreciate the young ladies. They have got almost all the answers right. And if I 1 or 2, I got one, but they got all right. So it shows the high level of awareness regarding the UGA bleed nowadays more or less standardized. There is no controversy about any of this management issues. This is how we go. One after the other, whatever techniques we have used, and similarly, the expert is also. Small question being an old time, but do you think supraplet has got any value here? Because any mucosal lesion, once we demonstrate this mucosal lesion, along with PPI or potassium droplets, supraplet have an additional value.
In terms of gastroprotection, sir? No, but the patient has got GI bleeding. We don't have these guidelines recommending the usage of sucralfate. But as a preventive measure, I think we are justified in giving those drugs. You mean after the first endotherapy, is there a role for sucralfate? I am not very sure because guidelines have not seen the usage of, apart from PPA, they have in fact compared PPA and H2 receptor blockers and found PPA to be better than H2RA, but they have not compared this with the other drugs like sucralfate. So all these things for primary prevention of GI bleeding, secondary prevention.
Misoprostol as a mucosal.
But somehow these guidelines they don't discuss about any of these drugs, sir. Actually.
But for erosive gastritis GI bleed, Misoprostol works, and it's even superior to PPIs in a few studies. I mean, I'm talking about at least what I read 10 years ago. But
Okay, sir.
now misoprostol is not discussed at all in any of these guidelines.
Exactly, sir. This is primarily for the panel, so you can also ask them to.
One small doubt, whether
To
when
teach-
you are
yeah, yeah.
guillotining said, how many times recent times you have done guillotining of the clot? Is it a primary care physician, experienced person should do this, or a person is, I feel there will be profuse bleeding whenever there is a 2B stage, Forest classification. The guillotining the clot is still, I feel, is still, whether you can do it in midnight, no. Only in the morning you can do, isn't that so? This is all bleedings, you should have a good team, otherwise don't enter. The more the primary non-nocere, you don't do more harm than the existing problem, that's what they say.
Yes, sir. Regarding the management of adherent clot, there is no consensus as yet. The guidelines say that we might guillotine the clot and then provided there is adequate backup available, because there can be uncontrolled bleed. In very few cases where we have attempted removing the clot with a snare, we had only minimal bleeding or no bleeding. So I think it is relatively safe, but we should always have the IR backup available. Sir.
I think with the current availability of PPIs, I think in infusion and all that, I think to meddle with the adherent clot in a situation where you don't have backup, I think is asking for trouble. I think most of these patients, I've followed them up. I think with a good dose of PPI, you call them for a relook, especially definitely do a relook in Forest 1 and 2. You will see that it becomes type 3, clean base.
That's a very valuable point, sir, because when you see the natural history of these bleeding ulcers, at one point it was bleeding, but soon after flushing it was a non-bleeding visible vessel which we saw. That only, so we can wait actually for the adherent clot, we can still wait. When we do endoscopy 1 or 2 days later, it would be sometimes a pigmented spot or sometimes a clean base ulcer. So it is which point in time we are doing endoscopy. I agree with yours.
You can go for a mechanical hemostasis, that is, put a clip below the clot, catching the mucosa on the surrounding areas. Then you can go for a attempt at removing the clots to see what kind of lesion it is. If there is any exposed vessel which is underlying the clot, then you can always do either an additional mechanical hemostasis or an electrocauterization. So as such, the PPI doesn't do anything more than clot stabilization. That is one thing. As far as the
Now, in high-risk bleeding, we have strong evidence only for a IV bolus followed by continuous infusion or intermittent IV BD treatment. But oral is also a good option when the patient is stable, taking orally, there is no vomiting and conscious. So there is nothing that should prevent us, because studies have found both are good enough actually. With regards to the adherent clot, it seems logical that we secure it first with a clip and then do something. But what the guidelines say is, we remove the clot. If there is active bleeding, you treat like a oozing ulcer, Forest 1A, 1B. After removing the clot, if you see a non-bleeding vessel, you treat like we can do a monotherapy with either a thermal method or we can go for a clipping. So it all depends on what we see after removing the clot. It is still controversial. We don't have proper guidelines.
One of the factors of bleeding is age, 60 or 65. Does your strategy change depending on the age of the patient? So if it's 60 plus, suppose he was much younger,
We don't have guidelines like that, but logically speaking, sir, all the atherosclerotic vessels tend to bleed. I think mechanical would be justifiably better, will work better compared to thermal methods. That's what you are trying to say, sir? Because we don't have guidelines which says that there should be a difference in the way we should manage ulcers with regards to the age.
Sometimes it looks easier to tackle rather than non-varicose bleed. Put a band and come away, put a glue and come away. If it occurs, EBL ulcer is a back problem, but it's a 2 minutes affair. We like affairs only, so that way it is. Varicose bleed is easier to tackle than non-varicose. It needs a lot of gadgets, some experience in putting the clips and all. Whereas varicose bleed, even I will just ask my staff nurse to put it. It's very simple. That's it. You don't do EST nowadays. If you do EST, that's a different matter.
Okay, sir.
There is any role for hemospray?
Hemospray, the guidelines says it is still got a role, especially in tumor bleeds. But then once you put this hemospray, we can't use another modality, and it works only when there is an active bleeding. So it has got a role. Definitely, it has got a role.
Oral PPIs for a GA bleed. One of the earliest studies, I mean, for the postgraduates, I think it's important to recall that one of the earliest studies regarding the role of proton pump inhibitors was from India. Any guess from where it was? Who published it? PPI, proton pump inhibitors in a GA bleed.
MSK?
Yeah, exactly. So it was from Kashmir, Kuru. So it was, at that time they didn't have an intravenous preparation of PPI. So what they used was actually oral omeprazole. Okay, so oral omeprazole versus control drug in the setting of a GI bleed. So I think that got published in some early 90s. NEJM or something. So very, I mean, one of the pioneer. Yes. So, I mean, it's one of the landmark publications that we should be aware of from Kuru's group.
I call upon the speaker, Dr. R. Deepak Kumar, Madras Medical College. The guide is Dr. Shanti Selvi, Assistant Professor, Madras Medical College.
So good evening everybody. First of all, I would like to thank TNSG for giving me this opportunity. Today we will be having a review of recent publications from India in the field of pancreaticobiliary disorders. My guide is Dr. Shanti Selvi ma'am. The first article is a review article. This article is about the role of endoscopy in patients with malignant hilar obstruction. This was published by Janvi Dar et al. And his colleagues in Annals of Gastroenterology. As we all know that malignant hilar obstruction, it often presents late with limited curative options. Biliary drainage forms critical for both palliation and improving quality of life. Pertaining to endoscopy, it plays a very good role in both diagnosis and therapeutics. Based on various studies, what they found was Bismuth's classification was the most commonly used classification. Diagnosis with pertaining to endoscopy, the most commonly used diagnostic tool was breast cytology. It had a very good specificity of around 90 to 100% with limited sensitivity of only 40%. This yield can be increased up to 60% if you increase your breast cytology passes for more than 30. When breast cytology is combined with liquid cytology and fish, actually the sensitivity increased up to 80%. With advent of cholangioscopy, it is now being increasingly used in patients with indeterminate biliary strictures, which has very good sensitivity and specificity of around 95%. Based on various studies, what they found was always to achieve the goal of effective biliary drainage in patients with malignant hilar obstruction. And the goal should be to drain at least more than 50% of the liver volume. Normally, our right hepatic duct drains about 60%, left hepatic duct around 30%, with caudate lobe around 10% of the total liver volume. Based on various reviews, what they found was unilateral drainage is always easier, but always try to achieve bilateral drainage in cases of advanced malignant hilar obstruction like lesions with bismuth 3 and 4 lesions. So when ERCP and PTBD was compared, what they found was ERCP was less invasive with better patient comfort and preferred in lesions with bismuth 1 and 2 lesions, whereas PTBD is better for altered anatomy and complex hilar lesions, but it comes with the high risk of dislodgement and discomfort to the patient. Whether pre-op biliary drainage to be routinely recommended, there are actually no RCTs to recommend this, but several retrospective studies show that there is increased risk of post-surgical infections in case of routine pre-op biliary drainage. So this indication should be limited to certain conditions like cholangitis, pruritus, neoadjuvant chemo, renal insufficiency and delay in surgery, sometimes with functional liver remnant less than 30% after surgery. So they have compared metal versus plastic stent for malignant hilar obstruction, and various studies have stated that metal stent is better than that of plastic stent. Though plastic stents are relatively cheap and easier to exchange, they come with the drawback of stent occlusion and stent migration, whereas SIMS, it comes with a large diameter, higher stent patency and low intervention rate, and on a long term it is cost effective too when compared with that of plastic stent. Looking at EUS, it has largely replaced PTBD and it should be considered as an alternative for patients with failed ERCP. When EUS and PTBD was compared, what they found was clinical success was similar in both the groups, but lesser adverse events and shorter hospital stay was noted in the EUS group. Looking at ablative therapies for patients with malignant hilar obstruction, they have, in various articles, they have used photodynamic therapies and radiofrequency ablation. This is actually combined with SIMS, and looking at stent patency and the survival outcomes, what they found was combined technique was better than that of plain SIMS. With pertaining to this, I have one more study. This is a pragmatic comparative study where they use a combined technique of endobiliary radiofrequency ablation along with SIMS for the betterment of outcomes in patients with malignant hilar obstruction. This study was published by Nitin Jagtap and his colleagues and published in Indian Journal of Gastroenterology. So this being a pragmatic study, the patients were given a choice to be in either of both the groups, like combined group and the SIMS alone group. All patients included were with ECOG status of less than or equal to 2. And they have, the primary outcome was improving the overall survival, whereas secondary outcomes was in the terms of stent patency, clinical success and adverse events. Looking at the technique, they have used an RFA catheter, which is a temperature controlled catheter, ELRA catheter. It usually ablates at 80 degrees Celsius for about 2 minutes, followed which a good balloon sweep is done and lateral SIMS placement is done. This is actually the catheter and it comes at various lengths, and in this study they have used 18 mm catheters and 22 mm catheters. Looking at a fluoroscopy image, you can see that first the guide wires are passed into the right and left system. Later RFA catheter is passed through one of the guide wires into the right system. Ablation is done. Then into the left system, ablation is done. Then a balloon sweep is done on both the sides and later SIMS is placed. Looking at technical success, it was 100% in both the groups. Clinical success was clearly better in the combined group than in the SIMS group. Likewise, adverse events rates were similar in both the groups with no major complications. As told, that survival and stent patency was better in combined group. Looking at other predictors of outcome, in this study they have included patients with GB carcinoma and hilar cholangiocarcinoma. And they found out was GB carcinoma is better in terms of survival and stent patency. And also in this study, they have given chemotherapy for about 1/3 of the patients. So after a good propensity matching was done, what they found out was chemotherapy actually improved stent patency in patients with hilar obstruction. So AS, Richer and ECOG status does not have any significant predictors of outcomes. There are certain limitations to this study. It was not randomized single center study. So we need further studies to validate this. Coming to the next article, this is about the outcome of neglected biliary stents for more than 5 years. This study was done by Sudhi Marshall et al. From SMS Jaipur. Totally they have included of about 40 patients. So mean duration of forgotten stent was at least 5.9 years. The most common presenting symptom was abdomen pain. The most common stent type they used was 7 French double pigtail stent. Looking at the outcome of this neglected stent, most of these stents had stone also along with it. So stone removal was successful in about 90% of the patients and stent removal was successful in about 80% of the patients. Half of them had stent reinsertion and 7.5% had broken stent, which was removed with the help of balloon or Sogandra's retriever. And 1 or 2 patients, they were not able to retrieve the stent because it got broken and impacted into the CBD, for which surgery was done. Looking at complications, it was no surprise that most of these patients had cholangitis, followed by internal migration and pancreatitis, and 1 patient had portal hypertension because of the clogged stent and secondary biliary cirrhosis. First of all, why were these stents forgotten? They actually asked the patients, and 70% was actually aware, but they ignored to follow up. 25% they believed that stent was permanent, and 5% were actually unaware of the stent placement. Clear communication gap between the treating physician and the patient. So the next study, they try to look at the predictors of stent migration in straight biliary plastic stents. This study was done by Aditya Kale et al. From Chem Hospital, published in Indian Journal of Gastroenterology in 2024. The aim of the study was to look at the stent migration rate factors associating with stent migration and retrieval outcomes. So this is a single center retrospective study. They have included of about 1,100 odd ERCP cases, and what they found out was around 6.5% had a stent migration. They used various retrieval techniques to remove those stent. The balloon catheter was the most common one, followed by Sugandhara stent retriever. A Daumia basket, snare and sphincterotomy were used in 1 or 2 cases. Looking at major 2.7% had major complication in the form of hemophilia. This patient had underlying factor VIII deficiency. This may be the cause of it. And one patient had mild retroperitoneal perforation, which was managed conservatively. So looking at the predictors, after a good propensity matching for age, sex and comorbidities, what they found out was stent size of 7 French and the stent duration of more than 3 months were associated with the risk of stent migration. So there are certain limitations, like it is a retrospective study, single center study, and there was no cholangioscope available for failed retrievals. They were taken up for surgery in this study. This study aims to look at a bacteriological profile in patients with biliary obstruction. Study was done by Neelakant et al. From Gandhi Medical College, Secunderabad. This is a retrospective study for 6 months. Actually, they include about 50 patients. And what they did was, all patients with biliary obstruction undergoing ERCP, bile was collected and sent for culture, and followed which antibiotic sensitivity testing was done. So common symptoms they noted was jaundice, fever and pain. 32% had cholangitis in this group, of which 11 cases was due to benign reason and 5 was due to malignant cause. Among the benign cause, the most common etiology for ERCP was cholelocholithiasis. Looking at the positivity in bile culture, the most common organism was E. coli, followed by Klebsiella and Pseudomonas. Polymicrobial growth was noted in about 16% of patients. Looking at antibiotic sensitivity, colistin, tigecycline and amikacin had a better outcomes in terms of sensitivity, like they had a sensitivity of more than 80%. The most common antibiotic that we tend to use in our ICU settings is meropenem, which had a moderate sensitivity of around 70%, whereas the conventional antibiotics like piperacillin, tazobactam, cipro, cefotaxime, cefixime and ampicillin has very low sensitivity. So clinically correlating, bacteriobilia was present in about 88% of patients with cholangitis. The mortality was noted only in the bacteriobilia group, and there was no significant difference between the culture positivity in benign and malignant cases. Like you can see here that both benign and malignant cases has a positive culture of around 65%. And also one more thing to note here is there was a positive culture in patient even without cholangitis of around 52%. This tells us the fact that even before the features of cholangitis, these patients tends to grow more bacteria in the obstructed biliary system. So coming to conclusion of this study, the resistant patterns are actually shifting. Each hospital should have their own antibiotic sensitivity pattern for effectively treating the patient. Colistin, tigecycline, amikacin has high sensitivity in this study. Empirical antibiotics like cipro and ampi are less effective. This study tends to look at the outcome of patients with acute pancreatitis in elderly versus younger population. Study was done by Rajiv Mehta et al. From Surat Institute of Medical Science, published in Indian Journal of Gastroenterology in 2025. Totally, they have included a patients of 500 odd patients, of which elderly more than 65 years was noted around 33% of the in this study group. The study period was between 2017 to 2024. Among the elderly group, the most common etiology was biliary pancreatitis, noted in around 75% of patients, whereas in the non-elderly group, it was idiopathic and biliary, followed by alcohol-induced pancreatitis. Coming to comorbidities, it was no surprise that elderly patient had more comorbidities. Coming to transient organ failure, it was noted more in the elderly group, which was contradictory as because necrosis was noted more in the non-elderly group. This may be because of the fact that transient organ failure may be due to age-related physiological decline rather than necrosis-driven inflammation. So persistent organ failure was similar between both the groups. Hospital stay was similar, and also they noted that stay of more than 15 days actually predicts the risk of mortality. So coming to mortality, it was not significant between elderly or younger population. What they noted were predictors of mortality were the persistent organ failure, necrosis, BICEP score of 3 to 5, and a hospital stay of more than 15 days. There are certain limitations to this study. Since being a retrospective and single center study, no long-term follow-up were noted and no propensity score matching was done. This study aims to look at fatty liver, psoas muscle mass and density in terms of sarcopenia and myosteatosis. in predicting outcomes in patients with moderately severe and severe acute pancreatitis. This was a CT-based retrospective study published by Pankaj et al. In Indian Journal of Radiology in 2025. What they did was they included about 198 patients with moderately severe and severe acute pancreatitis for a period between 2019 to 2022. These patients all had a baseline and a follow-up CT. This is a CT of the same patient. On admission, you can see that attenuation of the liver is comparable to that of the spleen, which means there is no fatty liver. Whereas on follow-up, you can see that the attenuation of the liver has decreased when compared to that of the spleen, which means that fatty liver has started to set in. And psoas muscle areas calculated at the level of lower border of L3 vertebrae. Attenuation was also calculated at the level of L3 vertebrae, and what they noted was the baseline attenuation parameter was a bit higher when compared to that of the follow-up psoas muscle attenuation parameters. So coming to fatty liver, it clearly increased to 29.3% on follow-up, but it doesn't have any significant association with severity of acute pancreatitis, mortality or ICU stay. Coming to the muscle parameters, psoas muscle mass and psoas muscle attenuation, there was a significant, statistically significant drop, and this drop actually clearly associated with the chances of ICU admission, surgery and death. So muscle quality loss in the form of sarcopenia, myosteatosis was a stronger predictor than fatty liver changes. Looking at the best predictor, the psoas muscle attenuation at follow-up, when it got reduced, which indicates underlying myosteatosis or muscle edema, was a stronger predictor of ICU stay, surgery and mortality when compared with that of psoas muscle area, which indicates sarcopenia. This is one study from North India where they tend to look at the role of endotherapy in patients with chronic calcific pancreatitis. Study was published by Yatu and his colleagues in Middle East Journal of Digestive Sciences. This study is both an observational and a prospective study done between 2018 to 2020. In this study, they recruited of around 67 patients and they measured outcomes in terms of pain by visual analog scale, HbA1c and fecal elastase levels for endocrine and exocrine insufficiency. So based on etiology, idiopathic was the most common cause. Looking at MRCP and ERCP findings, PD stones was noted in about 75% of the study group. Stricture in PD was noted in about 1/3 of patients. In CBD, stricture was noted in around 20% of the patients. And multiple stones was noted in around 55% of the patients. What they did was sphincterotomy in almost all cases. Balloon dilatation and hurricane dilatation was done for PD stricture in around 70% and 30% respectively. And PD stenting was done in about 1/3 of the cases. Totally, they took an average ERCP session of 2. So they were able to achieve complete clearance in about 62% of patients, partial PD clearance in 25% of patients, and failed clearance in around 12% of patients. So looking at the outcomes, pain relief was present in 78% of patients at follow-up. The mean visual analog scale actually dropped from 5.9 to 4, which was statistically significant. And they note better outcomes in patients with single stones, head or body disease with no strictures. Looking at other parameters like HbA1c and elastase, it was not significant. And what they concluded was endotherapy mostly in fact impacts pain relief and it is not associated with improving endocrine or exocrine function. This study was published by Jayanti ma'am from Gleneagles Health City. What they did was they compared aggressive hydration therapy with the standard hydration therapy for the prevention of post-ERCP pancreatitis. As we all know, a good hydration always improves pancreatic perfusion, oxygenation with reduced zymogen activation and inflammation. An aggressive hydration subgroup, ringalactate was given at a rate of 20 ml per kg per hour for a maximum of 1400 ml during the procedure, followed by 3 ml per kg per hour for a total of 2100 ml for a period of 8 hours after the procedure. In a standard hydration group, 1.5 ml per kg per hour was given during the procedure and the same rate was maintained after the procedure. What it did was they did both review analysis and a retrospective study. In the review analysis, there are various studies to suggest that aggressive hydration was better than that of the standard hydration group. And also there is one large open randomized flight trial where they found out that aggressive hydration was equal to that of standard hydration group. So they did a retrospective analysis. In both the groups, they had equal number of patients. All patients received rectal NSAIDs before the procedure, and mild post-ERCP pancreatitis was noted in about 6.6% of the patients. There was no hydration-related complications. There was no significant difference between the hospital stay and adverse outcomes. So what they concluded was risk of post-ERCP pancreatitis is low if the patient is adequately hydrated, not necessarily with aggressive hydration. This study is from CMC Vellore. They are looking at pregnancy outcomes in patients with early onset idiopathic chronic pancreatitis. The study was published by Sudeep Judge Chowdhury et al. In Digestive Diseases and Sciences in 2025. This is a single center study done at CMC Vellore. 50 patients were included with a total of 86 pregnancies. Inclusion criteria was disease onset should be before pregnancy, patient should be diagnosed with idiopathic chronic pancreatitis, and the age should be of at least 18 years of age. Looking at patient characteristics, the mean disease at onset was 18 years. 88% in this study group had pancreatic calcifications and pancreatic exocrine insufficiency. 10% had pancreatic diabetes. Out of 88%, only 10% were on PERT therapy during pregnancy, and there was no smoking or alcohol history. So looking at pregnancy outcome, 78% had successful pregnancies. Only some of these patients had induced abortions, spontaneous abortions, and stillbirth, which was comparable with that of the healthy woman data from various other studies. And they also looked at the obstetric outcomes, the rates of gestational diabetes, gestational hypertension, spontaneous pregnancy loss, preterm birth, and low birth weight, which was noted in the study population, was comparable with that of the healthy woman data, and it was not significant. What they noted was LSES was a bit higher in the study population. This may be because of the fact that the treating physician may be a bit skeptical about the underlying diagnosis, and they have lower threshold for a cesarean section. Looking at the pregnancy outcomes, it was successful pregnancy in 78% of the patients. So when the obstetric data was compared with that of the healthy data, the rates of gestational diabetes, gestational hypertension, spontaneous pregnancy loss, preterm and low birth weight was all comparable with that of the healthy population data. What they noted here was there was a bit increase in the LSES in the study population group. So looking at pancreatic pain during pregnancy, it was present in about 42% of patients. Mostly it was mild with a type A pain, relapsed remitting type of pain, and there was no CP related complications noted during the pregnancy, and there was no impact on any pregnancy outcomes. This study was published from AIIMS Delhi by Meher Gupta et al. They try to look at the subclinical PA in patients with chronic pancreatitis and its impact on functional consequences. So it is a cross-sectional prospective observational study. 120 patients were recruited. What they assessed was for pancreatic exocrine insufficiency in terms of fecal elastase levels, vitamin levels, and DEXA scans. Subclinical PA by definition, which means fecal elastase less than 200 micrograms per gram of stool with no steatorrhea, among which mild PEA means 100 to 200 micrograms of fecal elastase levels, and severe PA means less than 100 microgram levels of fecal elastase levels. What they noted was subclinical PA was noted across all stages of pancreatitis, like more than 70% patients had subclinical pancreatitis, and severe PA was noted in about 86% of patients, and clinical steatorrhea was noted in about 25% of patients. As you can see here, that steatorrhea was present only in the definite CP group and advanced CP group, whereas subclinical pancreatic exocrine insufficiency was noted in almost all the groups. Looking at the patient data, pain was present in about 84% of the patients. Idiopathic was the most common reason of chronic pancreatitis in this study population, and subclinical PA was noted in about 70% of patients. When overt PA and subclinical PA was compared, what they found out was diabetes was most prevalent in the overt PA group, and osteoporosis and osteopathy was prevalent in both the groups equally. So subclinical PA group patients had osteopathy, but there was no difference in osteopathy between the patients with subclinical PA or clinical steatorrhea, or even in patients without exocrine insufficiency. So severe PA actually predicted vitamin E levels alone, and there was no correlation with osteopathy, vitamin D levels, or stage of chronic pancreatitis. On a multivariable analysis, what they found out was CP severity actually predicts the prevalence of osteopathy. You can see here that patients with advanced CP had more prevalence of osteopathy than in patients with early CP and definite CP. So weight loss, vitamin D levels or fecal elastase levels were not predictors of osteopathy, and osteopathy was even present in the early CP group, maybe because of some other factors. So coming to vitamin deficiency in in subclinical exocrine insufficiency, vitamin D was significantly low in patients with severe pancreatic exocrine insufficiency, whereas vitamin D levels, as told, it was low in across all the groups, and deficiency was not significant between the overt or subclinical group. There are certain limitations to this study. Was a small sample study. They included only of about 100 odd cases, and the mechanism of osteopathy was not fully explored. Coming to the last article, this is EPICAP India. This study is ongoing study. They are trying to evaluate epidemiology of chronic and acute pancreatitis in India. This is done by AIIMS Delhi. What they have done is they have included about 10 centers. You can see here that they are geographically distributed across various regions of India, and from the south, CMC Vellore and Trivandrum Medical College is taking part in it. So this study is first of its kind with a multicentric epidemiological study on pancreatitis in India. What they are planning to do is a community-based survey for a prevalence of chronic pancreatitis. They are trying to include about 1 lakh plus odd cases for surveillance. Then hospital-based surveillance is also done across 10 states for AP incidents. So what they are basically doing is they are having a validated screening tool in the form of questionnaire. They have done a subgroup analysis for it also with a high sensitivity and specificity. This screening tool is given to the field workers to pick up cases, patients with chronic pancreatitis. Later they are confirmed by gastroenterologists in the tertiary care center. Once they are confirmed, they are planning to look at the data on risk factors like lifestyle, metabolic and genetic factors. So with this study, we will be able to assess the disease burden, and it also helps in resource allocation for future policy makers. Thank you.
India and the pancreatic disorders. There is any questions from audience? You're asking me the question to me. Prevent the stent migration.
Yes, because there was an article which was reviewed here, right? So they were talking about stent migration. That is the proximal stent migration. We are not talking about distal migration. We are talking about proximal stent migration. So how to prevent that? So how do we select the appropriate stent? Do we still need to use a straight stent because there is high chance of proximal migration again? Why not can we switch over to a pigtail stent? Or why don't we completely stop using the straight stents? Are there any disadvantages in using a pigtail stent as such?
Anybody would like to take the question? Ubal sir.
I generally avoided any kind of stents for pancreatic, but that depends upon the experience that you don't do stenting or not. But the problem is proximal migrate stent is twofold. One is almost impossible to remove that. So it is where the experience counts, whether you have a very good experience in taking out the migrated stents, you can attempt it. Otherwise, it is, I prefer, if at all anything, it is a single pigtail stents. So, you mean after a malignant obstruction in a biliary?
And I would think logically not
So I don't have much of the complications. I agree with Dr. Umar that if you stent in pancreas, then you need to be very sure that you communicate with the patient
to come back and then either have a stent exchange or probably remove the stent, because the problem with the pancreatic stent is that they might migrate into one of the side branches, and then it's very difficult to remove those stents at all. You can't do that. And I've had experience a couple of patients where the stent got desiccated, broken, and then it had migrated into the side branch. Then you can't remove that. You have to put a new stent and come.
We have a similar experience last few months. Few patients we put a spyglass also. What happens is the pigtail is gone inside the pancreatic parenchyma and perforated the parenchyma. And it's very difficult
That's what
to
happens.
remove.
And worst scenario is where you have a stricture in the head and you can't. You need to dilate, spike arch won't go. There's so many problems. It's much more easier to remove a biliary stent if they have migrated proximally. That's my experience. Others can give your inputs.
So the problem is that the current teaching is to prevent pancreatitis, you put a pancreatic stent. But the problem is most of them, they don't address the what are the stent complications. And so ideally speaking, that you do other things rather than putting a pancreatic stent in a setup where you are practicing alone or there is no much backup. Don't put pancreatic stent initially. You do either hydration, put an indomethacin, some suppositories, and do other things to prevent pancreatitis rather than placing a pancreatic stent.
Most of these patients have their stent elsewhere and come back to us for problem. Gokul, your center.
Regarding biliary stents or plastic stents, we generally put a double pigtail stent when the duct is dilated. That is one way to avoid migration. Choosing stent length, generally shorter patient may require a shorter length like 7 centimeters rather than 10 centimeters. We had a proximal migration of fully covered metal stent into the bile duct, placed for benign stricture and loss to follow-up. We had a tough time. We couldn't remove and ultimately the patient underwent surgery. Regarding migrated PD stent, the pancreatic stent migrate in inside the PD, very difficult to remove because the pigtail actually closes once it goes inside. It is very difficult to catch and remove. We put another pancreatitis because of the obstructed pancreatic ductal system. It's very, very difficult to manage. None of the gadgets could retrieve the migrated PD stent. So we have made it a policy not to get distracted while placing a PD stent. And we push the stent deep into the T2 and then retrieve the... Thank you, sir.
We'll move on to the next topic. Thank you.
I thank all the postgraduates who have taken part in this program, as well as the chairperson, Dr. Joseph, for taking us through this event. Now, before we move on to the CME part, I think we just have a... Okay. So, we'll take about 5 minutes to present our secretary report. So, I think we'll start off with earlier this month, I think TNSG endorsed meeting, that is Clinical's liver transplant meet, went off very well. I think it went off about 3 days and was well attended from people, from faculty all over India as well as abroad. And again, congratulations to Professor K.R. Palniswamy and Dr. Jayanti, both of whom are not here today, but I think they achieved they were awarded the Lifetime Achievement Award. I think a big round of applause to both of them. And Dr. Jai Verghese for conducting, and his team for successfully conducting this program. I would like to again, we are very proud that we introduced this TNISG postgraduate travel grant this year in our Tamil Nadu ISG meeting. And we are very proud that one of the postgraduate awardee, Dr. Deepa Janakiraman from ICH, who is here. I think she presented in the APASL meeting in Beijing, and she got the Young Investigator Award also. So it's really a proud moment that from TNISG, a person who's represented and has got a very nice award from the Asia Pacific meet, and I wish her well in the years to come, and she takes it forward in the research team. Probably when the professor is around, I think next meeting, we will be presenting her the award of rupees 1 lakh towards the meeting as well. Okay, congratulations to her. So as far as the research activity goes, the TNSG Plex study is already over and the manuscript is in the process of revision, and it will be submitted shortly for publication. The next study that is planned is the Tamil Nadu ISG study on hepatocellular carcinoma. I think Dr. Sumati is taking the lead. She has submitted it for the Institutional Ethics Committee approval in Stanley, and she has also requested that all the participating centers also kindly submit it for their Institutional Ethics Committee, so that once we get it, probably in the next 2-3 months, we should start off this epidemiological demographic study. Key forthcoming meetings would be the one, again, TNSG endorsed meeting will be the one conducted as an endoscopic meeting scope from May 30th to June 1st, 2025. And then we'll be running a biostatistics course for the postgraduates. It'll be a 2-day intensive biostats course on June 7th and 8th, 7th and 8th of June. It will be for it's most likely for the second year postgraduates. Professor Usha Datta, who is the HOD of gastroenterology at PGI, as well as the editor of Indian Journal of Gastroenterology, will be the course director, and she has consented, and there will be 4 or 5 faculty members who will come around. It will be a 2-day intensive workshop where you have lectures followed by breakthrough sessions where they will address each and every part of, hopefully they cover the majority of the biostats that we feel we are not very exposed to during our study time. So I'll request a presentation from Jem. I think there is a video that they wanted to play before we wind up.
Good evening. The next section will be the CME program. I welcome Professor Amarnath, the Professor Head of the Department of Radiology, Stanley Medical College. He did his undergraduate from Tirunelveli Medical College, PG from Madras Medical College. He also did his PhD from Madras Medical College. He is a fellow in the Royal College of Radio Diagnosis, and he has more than 50 publications. And one of his publications, I was very curious, MR appearances of saturated bile and associated with pancreaticobiliary disease. And in the next half an hour, 40 minutes, we are going to listen a wonderful talk. Welcome, sir.
Good evening, one all. At the outset, I would like to thank the organizers, Sheshadri and the ISG team for giving me this opportunity. In the next 30 minutes, I quickly show some basic MR imaging, and especially he requested to show the MRCP, so I am slightly concentrated more on the MRCP images. So this is about the technique. Usually we do MRCP after 4 hours of fasting, and 3 Tesla is usually much better than 1.5 Tesla. And we sometimes give negative contrast to suppress the background stomach or duodenal contrast filling. And the sequences we used in the hepatobiliary imaging is T2. This is the T2 weighted images. You can see the pancreas. And the fat suppression T2 helps to identify the peripancreatic edema. Usually we'll see the CT, peripancreatic fat stranding. In MR, in the routine T2, it is very difficult to see. If we use fat suppressed T2, then we can see the edema. The white one is the edema, that will be nicely seen. So fat suppressed T2 will be helpful. This is just a cystic lesion here, just to show the small side branch IPMN in the head of pancreas in a T2 weighted images. This is another T2, this is a normal T2 weighted imaging with the pancreas, and this is with the autoimmune pancreatitis, the sausage shaped enlarged pancreas with a loss of indentations, everything. It is a smooth sausage shaped enlarged pancreas in case of IgG4 disease. And if we drop, this is the technical one, if you increase the TE time, that is our technical time, if you increase the TE more, then in the T2 weighted images we can see the peripancreatic edema without doing any fat suppression. Coming to the common very important sequence is the T1. For the pancreas, it will be T1 imaging is very useful because it will be, pancreas will be homogeneously bright in T1. Whereas T2, it is very subtle. If this shows altered intensity, this may be pancreatitis or some mass lesion, everything will be PEST. So T1 imaging is very useful in pancreatic imaging. this is one pancreatitis. You can see the entire pancreas, instead of white, it is completely edematous and it is diffusely diseased with dilated main pancreatic duct. And another one is, this is T1, again we are doing fat suppression here, T1 fat suppression. Here in T2, peripancreatic edema is there. So whatever you are seeing here is the peripancreatic edema. And on T1 fat sat, this edema appears white. So this is an hemorrhage, peripancreatic hemorrhage. It's not a simple edema. So we can tell that is a hemorrhage outside the pancreas. This is outside the pancreas. With the T1, we can say it is a hemorrhage. Each sequence has a role. This is again a lesion sitting in the pancreas. Pancreas should be T1 bright. It will be homogeneously bright. Here, this body and tail of pancreas, there is a lesion sitting here. And we also give contrast to assess the pancreatic tumors. I will just show some of the slides. Coming to the other slides, other than T1, T2, we use diffusion plus MRCP sequence. Previously, we do thick slabs and thin slabs. That is a pre-3D era. Now we occur only 3D slabs, and then we can retrospectively do thin sections. Previously we do multiple oblique views to see the MRCP. Right now all is 3D. So this thick slab, thin slab is no more useful, because we are acquiring a volume acquisition and then we can do thin slices. So you can see here the pancreatic duct, there is a calculus, and there is a calculus in the distal CBD. And this is the normal MRCP sequence. The patient has a fluid in the bowel loops. If you are giving some pineapple juice or some gadolinium with water, then this all the background will be disappeared, because this is called negative contrast. We want to remove, then only we can nicely see the common bile duct and the MPD. Otherwise the background fluid, wherever there is a fluid, that will be seen. MRCP is nothing but a heavily weighted T2. Wherever there is a fluid in the acquisition, that will appear in the image. So stomach and the duodenum contains a lot of fluid. If we suppress the fluid with adding something which inhibits the T2, it will become dark. So like iron, we can give iron solutions or the blueberry or juice or pineapple juice before the MRCP, then that will suppress, then only we will see the main pancreatic duct and the CBD. So these are all the two examples after giving this negative contrast. Or we will give some oral gadolinium, then that will be suppressed. These are all the techniques to clearly visualize the pancreatic biliary tree. And this is usually we see the pancreatic MRCP in the coronal images, because everybody used to see the MRCP in the coronal, but you have to see in the axial. So because you see the right hepatic duct is here, left hepatic duct is here, both are not joining in axial sections. So that will be nicely seen with the axial. The same, because it is a 3D, we can do coronal, sagittal and axial planes. Similar, you can see there is a dilated main pancreatic duct is here, and axial sections you can see the duct is opening in the minor papilla, that is a pancreatic divisum. The major ventral duct is draining into the major papilla. So if you do axial sections, because there may be an overlapping both the ducts, they may not be seen in the routine conventional imaging. So you have to see it in axial also. So the first one is a Klatskin tumor, and the second one is a pancreatic divisum with chronic pancreatitis. Coming to the this slide, this is a side branch chain IPMN. Here you can see there is side branch duct dilatation here in the pancreatic duct. Right now we do 3D sequence, I told, so we can see each smaller dilated ducts with this 3D sequence. Each thin sections, we can see the entire side IPMN, which is dilated like this, is seen in this 3D MRCP sequence. Coming to the other indications for doing MRCP is to detect anomalous insertion of ducts. Lot of variations will be there. In this, you can see the right posterior sectoral duct drains into the left hepatic duct. And this is very important because the next topic is also, you are talking about the bile leak, where this abnormal right hepatic duct may insert into the cystic duct, or it may open into the common hepatic duct. So this is a normal healthy liver donor. We do MRCP because they want the length of the RHD, it should be more than 5 mm to do anastomosis. So we do. It is very difficult to see the normal person's pancreaticobiliary tree. And so if it is not visualized, then we have to give morphine and glucagon, so that morphine contracts the sphincter of OD, glucagon produce dilatation and secretion, so that you will see the entire pancreas in the normal patients, not with the pathological patients, so that they can plan the biliary anatomy before doing the transplant. And for the transplant, again, this is the various biliary tree patterns. If the RHD is draining into the left hepatic duct, then the left lobe resection is possible. Similarly, LHD draining into the right, then right lobe resection is possible. If it is trifurcation, then it is the left lobe resection they will do. Based on the anatomy, they can do the liver transections. This is one of the variants. Anyone would like to answer this? This is the RPSD, which is draining into the CHD at a lower level, and the cystic duct is also having a common sheath. It is going long common sheath. And this is a duplicated GB, sometimes intrahepatic gallbladder, so surgery they may find difficult. This is intrahepatic, an accessory duplicated gallbladder with a calculus. And again, this is an RP ST, which is draining low, very low into the common hepatic duct. Similarly, the cystic duct is also joining very low in mid and inserted medially. So these are all the normal variations you have to see in the MRCP before going for surgery. Other common indications, I think you know most of the conditions very well. I am not going to talk about all the conditions. The role of imaging is whether the cause is intrahepatic or extrahepatic, to know the level of obstruction, whether we can do a resection or palliative stenting is possible. Coming to the some congenital conditions that may be manifest in adult is the choledochal cyst. Here you can see the fusiform dilatation of the CBD without any obvious obstruction. We know that all the 5 types I am not going to show. Another case of cystic duct, this CBD dilatation, there is no obstruction. You can see the floating calculus within the dilated segment. There is no significant dilatation of the biliary tree compared to the CBD dilatation, and there is a long channel of the common channel of the biliary pancreatic tree, and the pancreas, instead of T1 bright, it is showing altered signals. There is a pancreatitis also in this patient. Coming to the other causes for obstructive jaundice, what is this? So there is a stricturing lesion in the confluence of the hepatic ducts. Very short segment, very short segment. Thereafter the CBD is normal. Both RHD and LHD are dilated. There is a stricturing type of tumor. There is a very small stricturing type of growth. There is no obvious mass lesion seen in this patient. This is another patient presented with obstructive jaundice. Any diagnosis on this? Again, RHD is dilated, LHD is dilated. There is no common hepatic duct is not visualized. So there is something they are causing this much. Distal CBD is normal. Anything else? There is a pancreatic divisum with Santorino seal is there. So the ventral duct is normal, and you can see this duct crosses. Usually the duct coming down and join with the main CBD and open in the major papilla. Here it crosses, so there is a pancreatic divisum in this patient also. So there is a Klatskin tumor here, and you can in the CT also you can see there is a mass here, and in MRCP this is the right hepatic duct, this is the left hepatic duct, and you can see the mass, very obvious mass sitting here. The previous one there is no mass, there is a stricturing growth. This is a mass. Obviously you can see the mass that is extending into the both the right hepatic and the left hepatic as well as to the common hepatic duct. And this is the representative images with the CT contrast. We are showing the CT mass. Where is the location? It is in the left hepatic duct, and this is the right hepatic duct. These are all the portal vein in relation to the portal vein, so that the surgeons will plan the surgery accordingly. What is this? Multiple strictures, intrahepatic and extrahepatic. Yes, primary sclerosing cholangitis. So multifocal strictures. You have to consider now IgG4 disease and other AIDS related cholangitis, also similar appearance. So this is a primary sclerosing cholangitis, multiple strictures and dilatations. If you do MR, you can see the thickening of the biliary tracts. So routine T1, T2 shows biliary wall thickening, and in MRCP sequence you can see multiple dilatations and strictures. And what is this? Again similar Klatskin, but this mass is so huge. You can see it's very huge mass. Not like the previous ones, it's a very huge mass. So conventional MR you will see a very huge mass, and in MRCP both the confluence is, both the hepatics doesn't meet, and the CHD also obliterated. This is a different patient. There is dilatation of predominantly on the left side, left lobar IHPR dilatation. There is a mass lesion here, and there is a volume loss. There is a retraction of the capsule also there. So this is a mass sitting here. This is an intrahepatic cholangiocarcinoma. So another patient, only the left hepatic duct is dilated. You can see the right hepatic duct is normal. CBD is there. Anything else? In the lower sections. What is this structure? This is a rectum. There is a growth. So colonic metastasis can cause biliary obstruction. So few of the metastasis cause biliary obstructions. So usually HCC won't cause biliary obstruction, but the cholangios and the metastatic from colon and some breast cancers, metastasis causes the bile duct obstruction, thereby producing segmental dilatation of the IHPR. This is again only left lobar IHBRD here. Inside the bile duct, left hepatic duct, there is a filling defect here. You can see it is in the duodenum or in the ampulla. These are all not the head of pancreas mass. So these are all adjacent to that. If the mass, the obstruction is well away from the duodenum, at least 2 centimeters or 1.5 centimeters, then it is causing obstruction of the pancreas. Then it is in the head of pancreas. Instead of saying a double duct sign, you can see this additional points, then you can differentiate this. They call this is a 3-segment sign because the dilated distal segment, normal distal pancreatic duct, and the CBD will be there. They call it as 3-segment sign. It is again a double duct sign only. It is a additional point. Sometimes this pancreatic mass may infiltrate the CBD also. then it may produce 4 segment. So they call it as 4 segment sign. Both are, but what you clinically see is the double duct sign. We will see here. Additionally, you will count these 2 4. So it is not the ampulla or the duodenal mass. It is obviously in the head of pancreas distally. So you know, when you see 4 segment sign, obviously you can say it is a pancreatic head mass, not the duodenal or the ampullary mass. Coming to other sequence, one sequence we do is the chemical shift imaging, where we do in-phase imaging and out-of-phase imaging. You have seen in the previous journal club also, they have put CT scan to see the values, to see the fatty liver. How we do in MR is in-phase if it is white and dark, out in out-of-phase means it containing fat. Fat is suppressed. So this liver has a lot of fat. If it is reverse, it is dark and outer phase it is fried, then it is hemocirrhosis. How we diagnose, and the hemocirrhosis is also very dark in T2 weighted images. So how the diffuse liver disease we diagnose. Coming to the pancreatic protocol, how we do the anatomy is just whatever structures below the SMA or SMV is the uncinate process, and the neck of the pancreas is the main portal vein, and between the main portal vein and the inferior mesenteric vein is the body of the pancreas. Distal to the IMB is the tail of pancreas. That is the anatomical way. So this is the uncinate, this is the head of pancreas. From here to here is the body of pancreas, and distal to the inferior mesenteric vein is the tail of pancreas. That is a normal anatomy of the pancreas. And the normal pancreatico-biliary junction should be within the pancreatic, this duodenal wall. If it is outside and the long, then there is a chance of reflex. Whatever the etiology has told for the biliary pancreatic pancreatitis or everything, there is a high chance of reflex from the bile to the pancreas or pancreatic juice into the bile can happen. So this abnormal pancreatico-biliary junction is very important. Here you can see in one example, there is a very long common chain. The MPD joins with the cystic duct quite early, and these are all prone for all the reflexes and all the complications. So this is one example to see the pancreatic duct is completely go around the duodenum. This is a case of annular pancreas. This is a case of pancreatic duct calculi. This is a pancreatic divisum with intraductal multiple calculi within the ducts. This is the classical example of a pancreatic divisum. Normally the pancreatic duct come like this and going down and joining with the ventral duct and united with the major papilla. Here it is crosses. So this is a case of a pancreatic divisum. These are all the examples of chronic pancreatitis with irregular dilatations and the side brain giving a centipede sign. And how to differentiate this from IPMN. IPMN also sometimes you will see the diffuse dilatation if it is a main branch duct dilatation branch type. In main branch there will not be any obstruction. The duct will be seen opening up to the ampulla. Secondly, the side branches will be cystic dilatation, whereas in pancreatitis it will be irregular because fibrosis, inflammation will be there, it will be irregular. That's why previously they call it as chain of beads or string of beads appearance of the MPD, because there is a multiple fibrosis will be there in pancreas due to pancreatitis. Whereas IPMNT it is smooth dilatation with side branch dilatation will be there. Whereas in malignant duct dilatation will be smooth, there is no side branch duct dilatation. By seeing this, you can differentiate various patterns. I will show few more examples. This is a known case of pancreatitis. There is a pseudocyst here, and there is a pleural effusion. And you can see the communication with the pleural cavity and this pseudocyst as well as the pancreatic duct. So from the pancreatic duct to the pleural, the pseudocyst, and then it goes to the pleural cavity. Sometimes we may demonstrate the communication if you are doing thin sections. This is a 70 years old female there is a cystic lesion in the head of pancreas. On CT scan, you can see the calcifications inside. This is a case of serous cystadenoma of the pancreas. This is a mucinous cystadenoma. There is no pancreatitis changes, only cystic lesion, pure multiloculated cystic lesion with the pancreas. This is not related to pancreatitis. There is no signs of pancreatitis. It is a multilobulated big cyst sitting in the tail of pancreas, turned out to be a mucinous cystadenoma. Another one doubt usually come across whether it is an inflammatory pancreatic mass or a true pancreatic adenocarcinoma. So in adenocarcinomas, you will have a smooth dilated duct, no side branch dilatation will be there. Whereas in case of chronic pancreatitis, the duct will be partially seen. It will not be completely obstructed. It will be seen. That is called duct penetrating sign. So this duct penetrating sign will be there in the mass forming pancreatitis, whereas in cancer it will be completely obstructed, and in cancer the duct dilatation will be smooth, no side branch dilatation, whereas in pancreatitis you will see side branch duct dilatations. And double duct sign, when you see the pancreatic head of pancreas mass, then it usually infiltrates the CBD. So bile, when you see a double duct, then it is a malignant lesions. And if you have a still doubt, then you have to see the diffusion, which is equivalent to PET, that shows diffusion restriction. Or even when you have a doubt, then we have to do a PET, that will be the final one that will shows increased metabolic activity. Or you can see sometimes the adjacent vessels. Usually the pancreatic carcinomas encase the vessels, SMB and SMB, so the shape will be altered, whereas in pancreatitis it will be preserved, always it will be preserved. By seeing that, we can differentiate this is a mass forming pancreatitis or adenocarcinoma. So these are all the, just to show the examples. When you don't see any side branch duct dilatation, it is most probably a carcinoma. Irregular dilatation, then it is chronic pancreatitis. When cystic dilatation of the side branches with non-obstructive, which it reaches the ampulla, then it is IPMN. Last one or two slides to show the role of diffusion weighted imaging. Again, you see a duct dilated in the tail of pancreas. You can see the pancreatic duct is dilated. Here there is a suspicious lesion. When we did diffusion, it appears dark. So this is an diffusion restricting a mass lesion sitting in the body of the pancreas, causing the duct dilatation. So one another example of pancreatic tumor sitting, causing this. Final topic what I am going to talk is the functional MRCP. That is, we may inject some contrast, gadolinium contrast, which may be excreted through the biliary tree. That may be useful when you have suspecting a biliary leak or something, then we can use the hepatobiliary contrast agents. Another one, if you are not able to see the pancreatic duct, then we have to inject secretin so that the pancreatic duct will be nicely seen. I'll show one or two examples. As I told earlier, when even the normal patients, when the liver donors, the normal biliary anatomy may not be visualized, then we have to give the low dose morphine and the glucagon. The morphine causes sphincter of Oddi contraction, whereas the glucagon causes the increased bile flow. So thereby you can see the opacification of the biliary tree. The phenobarbital again used in pediatric population to differentiate biliary atresia versus neonatal cholestasis. Here is one example. This is a conventional MRCP. There is a leak here. You can see that drainage tube, bile leak is here, but we don't know where it is leaking. This is the gadolinium, post-gadolinium functional MRCP. You can see this contrast is leaking here. So only the contrast will be seen here, and we are sure that it is leaking through the cystic duct remnant or here. So this will be useful for identifying this one. Another case, you can see this is a conventional MRCP, and this is the gadolinium which is excreted to the biliary. You can see the stricture, and this is just to show the dynamic MRCP. This is a normal gallbladder in a fasting. This is after a fatty meal to show the contractility, how the gallbladder is contracting. And this is some anastomosis, choledochal enteric anastomosis here. It looks like stricture because the conventional MRCP, it looks like a stricture. Post gadolinium, you can see the contrast is entering. So this is not a stricture, it is a post surgical change. There is no need to intervene. This is one another case of stricture of a transplant. There is a stricture here. Coming to the secretin, this is to show how the secretin causes better visualization of the pancreatic duct. Here without secretin, and this is with secretin. Another example of secretin injection here. This is again the side branches are not seen before injection of secretin, and you can see the side branches are seen after injection of secretin. So these few slides, secretin is, we are not using, these are all borrowed slides just to show the ways to see the pancreatic ducts. So to conclude, the MRCP is very useful in the pancreaticobiliary pathologies. Again, it is very useful when the obstruction beyond ERCP, we may not see some pathologies that may be seen, and extrinsic causes also to be very well seen. And I also told about the functional MRCP and the secretin MRCP, and additional T1, T2 and the diffusion helps to narrow most of the pathologies in the pancreaticobiliary tree. I thank you for your kind attention. Thank you very much.
I am a surgeon. So one of the problems we face with MRI in surgery is that we are unable to plan accurately the way in which we should go intraoperatively. One may be that we are using CT scans for a long time, and like you said, no, for pancreatic MRI, we actually do not get the right vascular involvement and the vascular patterns for us to actually plan.
So in the MR, it is very difficult to see the vascularity. For the pancreatic tumors, ideal is the CT to assess the pancreatic arterial anatomy and the venous anatomy better with the CT scan for the planning. For localization and all, MR may be better, the tumor localization.
The same problem I face with hyalocholangiocarcinomas. So I've stopped reading much into the MRI reports in a hyalocholangiocarcinoma. They are done by the medical gastroenterologist during the evaluation. But for surgery, we invariably have to go again with the CT scan, which gives us much thinner sections and a better delineation of the vascular involvements.
Yeah, vascular will be definitely seen with the CT scan, whereas the biliary tree we will not see with the CT scan. For the biliary tree, we need MRCP. Even for the liver transplant, they will send only for the biliary tree, they will for MRI. Rest of them, they will, the volume, the venous anatomy, arterial anatomy, everything they will do with the CT scan.
Perfect, understood. From the transplant point of view, we find that whenever you have a Huang A4, that is the problem. I think the duct is either very small, the Huang A4, where the right posterior septal duct goes and empties into the common hepatic duct. That probably is difficult to delineate from the MRCP, and we have seen where the posterior septal duct is invariably missed after a live donor transplantation. Do you have anything to make it better?
So usually
you showed a gadolinium contrast.
So we usually see the RASD and RPSD. Otherwise, we will ask the patient again to come on the next day, because it is very, they cannot take a decision on the table. So unless we are not seeing, we will repeat. Another way is to see, we do the kernel sections, we do axial MRCPs. There we can trace the smaller hepatic ducts, whatever we are shown here, no? So that will be seen there. So we do axial MRCP also, if it is not visualized, so that we will see the RPSD draining into the common hepatic duct lower also.
In those cases, sir, do you think gadolinium contrast will really help us?
Maybe. For the, but it is a donor, no, that's why we are not giving, that's why I told the other options. You have to contract the sphincter of OD so that the bile flow will increase by giving glucagon, and so thereby we can see the biliary tree.
Any other questions,
Dr. Amarnath, it's a nice question.
And the many other patients may not come with the fasting and all, so we may not see also.
Dr. Amarnath, a good lecture.
Yes.
A basic question. will it be possible to differentiate choledochal cyst from a dilated CBD?
Yes, sir. So in choledochal cyst, there will be a asymmetric dilatation, sir. There will not be, you will not see a smooth narrowing. There is a sudden dilatation as I is shown. Second one is the disproportionate, the IHBRD will be small. It will be only focal segmental dilatation. The doubt comes when it is the entire CBD is dilated. There comes only the doubt whether it is a choledochal cyst or something in the distal CBD cause. If it is a focal, then it is very easy that you can see the diagram and see, distal part is normal without any obstruction. And usually you will see the floating calculus. You see there is a floating calculus also.
The problem happens for us surgeons, like how sir said, it is in the early cases, they report as suspected type 4A choledochal cyst in a patient who has a classical symptomatic cholelithiasis. The duct is not just touching 1 centimeter.
So what you are saying is the early dilatation. Early dilatation involves only the CBD. Thereafter you will see the dilated RHD and HBRD. Correct, sir? So again, but there will be an entire CBD will be dilated. That will not be dilated like 1.5 to 2 centimeters. So whereas the choledochal cyst will be dilated, usually will be 1.5 centimeters or 2 centimeters. And it, in the adults, it will be from the congenital. So there may be other cholestasis and other cholelithiasis may be there. All CBD calculus may be there. Stasis calculi may be there.
Thank you, Amarnath sir.
Thank you,
for
sir.
the discussion.
Thank you.
I think we'll move on to the next panel. We would like to invite Dr. J.K. Jamil from the Department of Surgical Gastroenterology, Apollo Hospital, to moderate the session. This will be on bile duct injuries during cholecystectomy, prevention and management. And the panel, Professor from the Department of Surgery, SRM Medical College, Dr. J. Loganathan, who is from the Department of Surgical Gastroenterology, Madras Medical Mission, Dr. Saravanan from the Department of Surgical Gastroenterology, Stanley Medical College, Dr. T.K. Anand, Medical GE from MJ Muller Hospitals, Dr. Vadivel Kumaran from Kaveri Hospitals, Medical Gastroenterology, and Dr. Periya Karpan from Interventional Radiology from Omundarar Medical College. That's a very eminent panel. Thank you.
Thank you, Chairpersons Dr. Ilango and Dr. Ramkumar. First of all, I would like to give my heartfelt thanks to Dr. Parama and the members of the Tamil Nadu chapter of ISG for inviting me to moderate this panel discussion on bile duct injuries in laparoscopic cholecystectomy. How do we prevent it? How do we prevent it and how do we manage it? So, to help me discuss this topic over the next 45 minutes or so are very young and enthusiastic panelists from across the city. I think we've got a good variety here. We've got consultants from corporate hospitals, from government teaching institutions, private teaching institutions. So basically, we've got 3 surgeons, Dr. Tarun, Dr. Saravanan, Dr. Loganathan, 2 medical gastroenterologists, Dr. Anand and Dr. Vadivel Kumaran, and 1 interventional radiologist, Dr. Periya Karpan. Thank you so much, all of you, for coming. Let's see how it goes. So I want to set the scene by saying a few things about bile duct injury. This is a serious complication of laparoscopic cholecystectomy. Thankfully, it is very, very low in number. We are looking at 0.3 to 0.5% of the total laparoscopic cholecystectomies. But the problem that we're talking about here is that it is 0.3 to 0.5% of the millions of laparoscopic cholecystectomies that happen worldwide. I mean, if you look at surgeons, many of the surgeons, even in the city, perform hundreds of them in a year, and when hundreds or thousands of surgeons numbers are taken into account, that 0.3 to 0.5% is a number which cannot be ignored. life, the survival of patients, and it has some medical legal liabilities as well, which I'm sure all of you are aware of. The worrying thing is that 70 to 85% of bile duct injuries, they don't get recognized at the time of laparoscopic cholecystectomy. So I want to start off, perhaps I can start from you, Dr. Tarun. What are the risk factors for bile duct injury? Why do they happen? Can somebody switch on his mic, please? Mic.
Good evening, sir. So start with congenital anomalies. History of pancreatitis or cholecystitis.
Yeah. I mean, is there any specific way by which you want to categorize your risk factors? Yes, I agree, congenital, so that's an anatomical factor. Cholecystitis, pathological one. Dr. Loganathan, would you like to add to it? Why is this particular lab chole at a higher risk of bile duct injury than something else?
The time of presentation, the symptoms.
Yep. Sequence, time.
And then the findings, the anatomical variations.
Yep.
And then the non-modifiable risk factors like
what?
Male, gender, obesity. These are also will add to the risk of bile duct injury.
Okay.
And whether it is elective or emergency setting.
Elective or emergency, yeah. Right.
That plays a role.
I think you mentioned that earlier. Timing of surgery, right?
Timing, yeah.
Okay.
How early we are doing and how late we are doing, that also determines. And any anatomical variations, and then preoperatively any jaundice, that also will change.
Okay.
It will make it difficult. And
Dr. Saravanan, what about the surgeon himself?
Yes, these risk factors, it starts from the beginning of the patient's comes into my clinic.
Right.
Like the way he presents, whether he has got any jaundice, fever, inflammation, then
Right.
coming to the signs also, if there is any more, count is more, like acute inflammation, Mrs. syndrome, all these acute cholecystitis, and if the patient presents after, might be the timing more than 72 hours, or if there is more than, at least we can operate till 10 days. More than 10 days, the inflammation is more, then there is more risk factor for bile duct injury.
What about the surgeon himself? Do you think that is a factor in itself, or you don't think so?
Yes, all the factors put together, like anatomical factors, surgeon factors, clinical presentation, everything put together plays an important role. That plays, from that itself you can identify the risk factors and make sure you have a reduced bile duct injury.
So I think that slide summarizes more or less what my three panelists have just said. The anatomical factors, patient-related factors, and then the pathology itself. Is it cholecystitis acute? Is it an empyema? Is it a shrunken, shriveled gallbladder, chronic calculus cholecystitis? Is it an emergency or is it an elective? And I have put the word surgeon factors in capital because I believe that is a very important factor, right? We'll come to that in a little while. Let's start again. Tarun, I mean, these are questions directed to surgeons, so I'll have to stick to you three first, and then we'll come to you three in a little while. So what are the surgeon factors? Why is surgeon A more likely to develop a bile duct injury than surgeon B?
Every surgeon during his course.
Anybody can get it. I mean, but I'm just saying, what could be the reasons?
The reason is in the initial practice, one should have some kind of mentor.
Fine, fair enough. Learning curve. Anything
Learning
else?
curve.
Say if a surgeon has gone past the learning curve, right? There are still some reasons as to why he or she is more likely to get a bile duct injury than his colleague.
Not following the principles, not identifying the critical view of safety.
Yeah.
Not
So it could
according
happen
to the
anybody
protocol.
at any time. Yeah. Anything else, Loganathan?
The one important surgeon factor is the visual perception, misperception of laparoscopy. So that is also plays an important role for the surgeon. Even though we identify critical view also for safety, especially in laparoscopy, we lack a 3D, there is a visual perception will be the main contributing factors. Of course, the initial, the learning of laparoscopy of 25 cases, 50 cases, after also then, once they gain experience.
Great. I take your point, Dr. Saravanan. How many lap cholis should a surgeon have done to have come to a stage where he is safe and his chances of developing, his chances of giving a bile duct injury is less than what the literature is quoting? What's the number?
So even though it is not a generally prescribed one, any surgeon, even a good surgeon, experienced surgeon might get the bile duct injury. But there will be a reduction in the bile duct injury if the patient, if the surgeon is more experienced and if he is a specialist HPP surgeon.
I take your point 100%, but the literature does suggest a number, right? What it says is, yes, it can happen during the learning curve, but then for surgeons who have gone past the learning curve, the first bile duct injury happens when they are between 200 and 300. The first bile duct injury happens somewhere around the 250 mark. That's purely because they've seen it all and they feel that they know everything and they're so confident, and it doesn't always have to happen. This is not this is what the literature says. These bile duct injuries do not have to always happen in any of those difficult ones that you said earlier. These can be simple and straightforward gallbladders, and it can happen because of overconfidence. And then the thought of wanting to finish surgery quickly, fatigue, tiredness, and the last line there is probably a very important line. We'll talk more about it when we come to the case scenarios. When in doubt, there should not be any hesitation to call somebody for help. If you're not sure, if you think, is it a bile duct or is it a cystic duct? No harm asking someone who's next door, operating next door, or taking a photograph and sending it to someone and waiting 10-15 minutes. No big deal. It saves several years of problems for the patient, right? So that's quite important. Let's move on to some cases. So this is a lap chole done in a fit 40-year-old woman. According to the surgeon, it was an uneventful procedure. First day post-op, 350 ml in the drain, frank bile. The patient hasn't got any peritonitis, but on day one ward round, she's got a bit of a tender upper abdomen, slightly more tenderness than what you would expect for a lap chole. I mean, a bit of tenderness around the port site is acceptable, but this is outside that area. Apparently, she is not mobilized the previous night, and the drug chart says that she has had one tramadol injection, which is again out of protocol. I mean, why would you want to give tramadol injection for a simple and a straightforward lap chole? Vitals are normal. LFT is not routinely done for lap choles, uneventful lap choles on day one, but then because of the problems and because of the fact that she was not quite right, the duty doctor, whoever was on the previous night, had asked for LFTs and they came back as normal. What would you do, Dr. Saravanan?
Since it is only the first post-operative day on the 350 ml of bile, and the patient is stable, not showing any signs of any infections, so I'll wait and watch initially, and I'll see whether there any bile, there is a low fistula, or the drain is coming down.
There is bile coming out. There's 350 ml of bile in the last 24 hours.
Yes, sir.
Yeah.
I'll wait for another couple of days and see whether the drain is coming down.
You will wait. Fair enough. Can I ask you to pass on the mic to Dr. Anand? Dr. Anand, you're a medical gastroenterologist. Say this is a patient that you had referred to your surgeon colleague, and the patient is known to you, and you see the patient as well in your ward round. Bile, not quite right. Lap chole, uneventful according to your friend, your surgeon friend. Let's say your surgeon friend there has said like what Dr. Saravanan has said, let's wait and watch. Are you okay with it, or do you want to
Yes, I
get
think
into an ERCP?
we can wait and watch because there is a drain, and even if it is it will become a controlled fistula.
Yeah.
So once there is a drain, we can wait and watch.
You will wait and watch.
Yes.
Dr. Vadivel Kumran, you will, I mean, what's your view? Would you wait and watch, or would you push your surgical colleague to get an ERCP done for the patient ASAP?
So there's no need for an ERCP as of now. I would still wait because you have a drain. There is nothing collected inside. So I'm not worried about any
Correct.
bile collection inside. It is still coming out. It's well and good. There's no point in doing an LFT now because we don't have any collection inside. There's no point in doing an LFT at all in this case since the bile is getting drained out. I would still wait for at least 10 to 14 days time. Let us wait and watch.
So more than the volume of the bile that you have seen, it is the fact that the patient is clinically well. Am I right? Patient has got normal vitals, no peritonitis, a bit of problem with mobilization because of the bile leak in the upper abdomen causing localized, peritonitis, but patient is not that unwell. So you would wait with the hope that it might settle down in 2 days or 3 days. Yeah. So how long will you wait?
I would like to wait for at least 10 to 14 days time.
Sorry?
10 to 14 days, at least
10 to 14 days.
Yes.
Right.
It is a control fistula. It would gradually, it was an uneventful surgery, right?
Well, according to the surgeon, it was uneventful.
Yeah, that's what. I will
But
still
then,
wait for the things to heal. It will close by itself.
Okay, fine. So we'll stick to that, right? However, this particular patient went on to have an ERCP, right? And that's what the ERCP showed. It was a cystic duct blowout, and it was frank bile coming out. Would it change your thinking? I mean, you wanted to wait as well.
Yes.
In fact, all of you wanted to wait. Would it change your thinking? Are you okay with it?
Once I get in for an ERCP, even a sphincterotomy alone would suffice. Not even a stent over here.
Great. Fine. I think that's a very reasonable approach. I mean, waiting and watching, because it is only 18 hours and the patient is well. There's a nice fistula there. I mean, there's a nice controlled fistula there. You can always change your decision, 2 days later or 3 days later if the patient develops any further problems. And I'll entirely agree with that approach. So what does the literature say about it? Well, this is a nice flow chart. So if you have a look at it, if there is a drain and if the patient has got no peritonitis or sepsis, the standard advice is you just wait and watch. Wait and watch, but then you got to keep looking at the drain output. If it is anywhere around the 200 ml mark, you're fine waiting and watching, but if it just goes a bit beyond that, remember, what you're seeing on the drain is just tip of an iceberg. Bile is very notorious to be percolating through various bowel loops. There may be 350 ml out, but there may be another 300 ml inside. But the chances are with a cystic duct blowout, having liters inside in 2-3 days time is quite low. We are not looking at a major bile duct injury. But the teaching is, if it is around the 200 ml mark, you can wait. But then if it goes up, consider ERCP and stenting. But all of this in a stable patient, like our patient here. If the patient has got peritonitis, then the pathway is quite different, and we won't go into it. We'll look at the other scenarios. So just before I go to the to the other case scenarios, just want to cover some theoretical part of it. Bile duct injuries are classified into several types depending on the type of classification, the classification that you look at. The most famous one is the Bismuth classification, proposed in 1982 by Henry Bismuth. This was in the open era, in the era of open cholecystectomy. And this is based on the level of injury from the hilum. 1986-87 is when lap choles came in, and 1995 Stephen Strasberg came with this classification called the Strasberg classification, and there are a few things different in the Strasberg classification, which was more relevant to the laparoscopic era. There are other classifications as well. Mike McMahon from UK came with this classification in the same year as Strasberg, and then there's a very popular classification called Stewart-Ray classification, which not only looks at the level of injury, but also about the mechanism of injury. So that's a Strasberg classification. Whatever you see on the top half is minor bile duct injury. and whatever you see in the bottom is major bile duct injury. So it's basically A, B, C, D, E, and E is divided into 1, 2, 3, 4, 5 based on the bismuth classification, which is based on the injury from the level of the hilum. So that's the bismuth. I won't go into the details of this. So bismuth in Strasbourg in one tabular column. Right. Just want to say a couple of things about this. Any one of you in the panel familiar with this atom classification? I'm asking this question because it's not that popular, but it's a fantastic classification, and it has a lot of relevance in the context of bile duct injury. Do you want to take the question?
Yes, this is a recent classification which encompasses.
To be honest, it is about 10 years old, not that recent. 2013.
Which encompasses even my PG period. We are not used to this one.
Yeah.
Nowadays it has come.
How many of you in the audience familiar with the atom classification for bile duct injuries? Not many. Yeah. Go ahead. Sorry.
Yeah. This one encompasses all the factors. Correct. Like mechanism of injury, type of injury, biliovascular injuries. So everything it is put together. It has given, even though it is extensive, it has to be used because the mode of injury is identified. So that the future damage can be rectified with this.
Absolutely right. So that's what ATOM stands for: anatomy, timing of injury, mechanism of injury. Bismuth doesn't talk about mechanism. Strasbourg doesn't talk about mechanism or timing. So this is quite an exhaustive classification for bile duct injury, to such an extent that if you read the papers in the recent past, they will tell you that when there is a bile duct injury, and if you are the surgeon who has inflicted the bile duct injury on the patient, and you are referring the patient to a tertiary referral center in the Europe or in the UK, you're supposed to fill that form, so that the receiving surgeon knows exactly what happened. Is it a diathermy related injury, or is it a scissors related injury, or is it energy device? So it's quite an exhaustive description, and I would recommend the postgraduates, particularly the surgical postgraduates, to look at it in more detail. Right, back to the panel. What can, Dr. Loganathan, what can you as a surgeon do in your practice to prevent a bile duct injury? Because that's the focus here, isn't it? First is prevention. I mean, the next is management. So what can you do as a surgeon to prevent a bile duct injury?
It has been described. We have to try to achieve the critical view of safety.
Okay, you will want critical view of safety.
And
right.
I would like
What is critical view of safety? Perhaps for the benefit of the medical gastro postgraduates.
Yeah. So the lower 1/3 of the bile duct should be cleared off the liver, so that liver parenchyma should be visible, and after the callo dissection, only 2 structures should be seen entering into the.
So only 2 structures. Fine. What are they?
The cystic artery and the cystic duct.
So say you're the professor. You're the professor in SRM. I know that. So Tarun, your trainee is quite enthusiastic, and he wants to demonstrate the junction between the cystic duct and the common bile duct. He wants to be sort of 110% certain. Are you happy with that? Will you be happy with that?
It depends on the case, whether it's simple or not. But
no, but I'm asking you a question for a specific reason.
Yeah, not really, actually.
Yeah, the answer is it's not required.
Yeah,
it's not required.
Absolutely.
You have to demonstrate the cystic duct Hartmann's pouch junction during surgery. Going all the way down to the cystic duct bile duct junction is not required. In fact, it is recommended not to. So you have to discourage your trainee from going that far, because that's where the bile duct injuries happen.
What we say is stay above the lymph node of lung.
Yeah. So basically, if you stay above the lymph node, you will not be in that area between the cystic duct and the bile duct. Okay. It may look like a nice picture when you go all the way down, but that's creating a nice picture for no extra benefit, right? So that's something that junior surgeons have to bear in mind. Don't go all the way down. So. Yeah, I think as Dr. Loganathan said, critical view of safety is extremely important. When in difficulty, there are a few bailout procedures that as surgeons we always practice, and that's antegrade dissection or do a subtotal cholecystectomy. I mean, time doesn't permit me to go into the details of all of that. And then most important, look for the anatomical landmarks, the Ruvius sulcus and the cystic lymph node. Right, Dr. Vadivel Kumaran. There are three things right at the bottom that I have mentioned as possible adjuncts which may help in the prevention of bile duct injury. What are your thoughts? Why don't you talk about, laparoscopic ultrasound, and perhaps we'll get the radiologist to give us more input on intraoperative cholangiogram. I mean, does it really help?
So, laparoscopic ultrasound, I don't think as of now we are not being using it as such. So, if such a probe is available, it may be still be useful to determine the anatomical structures, which is beyond the critical view of safety, so that we can isolate the bile duct proper. That will be much better option of avoiding a bile duct injury as such.
What about an intraoperative cholangiogram, Dr. Periyakaruppat?
So in the present day practice, for an elective cholecystectomy, there is no role for intrahepatic cholangiogram.
Why do you say so? I agree with you entirely.
Because so much non-invasive tools are available.
100%. Sorry?
So much non-invasive tools are available.
Correct.
You can do an MRCP.
We just had an excellent lecture about MRCP. When we have pictures like these generated for us by our radiology colleagues, why should we do an intraoperative cholangiogram, right?
That could give the better picture of so many variations, whatever complications which could be encountered, which could be avoided. The only thing, these type of cholecystectomy complications, sometimes when you do it on an emergency basis, or
when would you feel that a surgeon's intraoperative cholangiogram will be of more value than your MRCP?
already the patient is having an injury, leaking is there, when you're not able to demonstrate in any modality, then it comes into the picture.
Perfect. So on table, when there is a problem for troubleshooting, yes, intraoperative cholangiogram. But routinely intraoperative cholangiogram, no, absolutely there's no evidence for that. In fact, let's look at what the SAGES says in a little while. By the way, that's a critical view of safety. That's what Dr. Loganathan was alluding to. You just need to see two structures, cystic artery, cystic duct, and then the inferior surface of the liver should be right at the top. That's how intraoperative cholangiogram is done. I mean, there are specific indications. I mean, they are done when the LFTs are deranged preoperatively, when there's a history of jaundice, history of gallstone pancreatitis, unclear anatomy, and all of that. See, these are from the literature from about 20 years ago. I remember one of my consultants in Leeds used to do an intraoperative cholangiogram for all his elective, uncomplicated lap choles. Full stop. There's no criteria there. Why would he do it? Well, he tells me that there's a 20% chance that there will always be an asymptomatic bile duct stone which will cause problems in the post-operative period. Fair enough. He was right for his time. But then 2002, 2003, when MRCPs came in, and the last 20, 25 years, they've just got better and better. And right now, 2025, there is no justification for routine use. And that's exactly what SAGES also says. Surgeons should be familiar with IOC so that they are able to use it at the time of need when there is a bile duct injury. But routine use remains controversial, right? With regards to laparoscopic ultrasound, I think you were right. I mean, how many of us in this room know? I mean, I don't know how to do a laparoscopic ultrasound. Number one, ultrasound probe, a laparoscopic ultrasound probe is extremely expensive. We don't have one in Apollo hospitals. I'm not sure if any other surgeon has experience in laparoscopic ultrasound. Okay, well, do you want to say a few things about it? Because I have no experience on laparoscopic ultrasound.
On laparoscopic ultrasound we used to do, but the literature support is not there to reduce the bile duct injury. Might be to identify the bile duct injury, laparoscopic ultrasonogram might be useful.
So do you do
even though we are using during transplant and all, not transplant.
Yeah, but that's open. That's open ultrasound.
Open.
I'm not talking about open transabdominal ultrasound. I'm talking about a laparoscopic ultrasound. This instrument here.
Yeah.
Do you have that?
We had, but we are not using nowadays.
Really? Yeah. Okay. Anyway, there's only one surgeon in South India that I am aware of who does laparoscopic ultrasounds.
During my PG time we had, but we are not used extensively.
Fair enough. So anyway, so the point here is it's a great instrument to have. There is a learning curve component as a surgeon if you want to know how to use it. I mean, putting it in that, I mean, keeping it in that callous area is not rocket science. Anybody can do it. Any surgeon who can do lap chole can do it. But interpreting it, that's where the difficulty comes in. And people used to go on courses. Surgeons, there's a course called ultrasound course for surgeons that surgical registrars in the NHS used to do. It takes a while. It's all down to learning curve. But you're right. Even if you have mastered that, is it really going to help you in reducing the chances of bile duct injury? Answer is no. Okay. So that's a SAGE's recommendation. It has some advantages over IOC because there's no radiation involved, but then reduction in bile duct injury is still a controversial thing when you have all these adjuncts. Fluorescence, who's used fluorescence? Have you? Okay, Tarun?
Yeah. For routine lap choles and uncomplicated lap choles, it does show the picture beautifully.
Yeah, it does.
But the problem is when there is extra fibrofatty tissue over the callus, then the sensitivity is low.
Correct.
Of course, when there is acute cholecystitis as well, when there is inflammation, the sensitivity is low.
Also, when there is a stone stuck in the because you really want the dye to reach the gallbladder. If there is a stone which is stuck
blocking,
in the
so
it
it
doesn't
doesn't
okay.
take up.
Yeah, I mean it's not expensive, by the way. It's not like buying a laparoscopic ultrasound which goes into lakhs of rupees. It's just indocyanine green. But right now there's a shortage of supply of indocyanine green, so there's not been indocyanine green dispatched for several months. But we use it. Does it really? It's cheaper. It's got no radiation, all that is fine, but does it again really reduce the bile duct injury? Probably not. Okay, but it's good for us to know all these things as adjuncts to reduce the bile duct injury. So back to some cases. So this is a lap chole done by a surgeon in a tertiary referral hospital. The surgeon talks to you and tells you that it was a difficult dissection. He's done the callus triangle. He's clipped the cystic duct. But as he was taking the gallbladder from the liver, he sees something golden yellow coming out, and he's pretty sure that it is bile in the liver undersurface. Quite rightly, he stops. That's what the surgeon is supposed to do. And then you arrive. You're there in the same hospital, and you go there to help. Dr. Loganathan, what would you do? Okay, what could have possibly happened? Answer that question first. Cystic duct nicely done, cystic artery done, your callus critical view of safety done, but as he is lifting up, golden yellow bile.
Accessory duct is a possibility.
Okay.
If cholangiogram.
So what's the significance of, sorry to interrupt, why did I say golden yellow bile? Why not just bile?
It's from directly from the liver.
So I hope that's familiar to the postgraduates here. Golden yellow bile at the time of lap chole means bile coming from the biliary system, the main ductal system. Gallbladder bile may be golden yellow, may not be golden yellow. But then if it is coming from the ductal system, it's almost all the time golden yellow, unless of course you have some cholangitis and abscesses and things. But so this is a patient who's just come for symptomatic cholelithiasis and you're seeing golden yellow bile. So you think there's an injury there? Right. So what would you do?
If it is what the protocol says is if it is less than 3 millimeter, we can ligate it, suture ligate it. If it is more than 3 millimeter, then it needs to be have a biliary enteric diversion.
Right.
But
okay.
this 3 millimeter, I have a question. I don't know how to.
Okay. Assess it. That's the surgeon in that hospital is experienced in doing intraoperative cholangiogram, and he knows that it needs to be done in this particular scenario because he's had a problem. He's done that. I know it's not a great picture. Yeah, there's a leak. Leak from common hepatic duct. Common hepatic duct. Agreed. So that's enough for now, isn't it? I mean, all we are interested in is there is a leak, right? So that's where the golden yellow bile came from. And the second good information that you get in that picture is, just ignore the clips, ignore the pad which has got some X-ray wiring and things. So Number one, there is a leak, and number two, great, fantastic. Two correct answers. That's the kind of information you want in an IOC. Is there a leak or not? And then is there proximal filling or not? If there is proximal filling, then we are okay in the sense, there's a room for salvaging. And now we need to deal with the leak. Back to a surgeon, right? Saravanan. So that was a lateral injury to the common hepatic duct, and it's a clean cut, no tissue loss, golden yellow bile coming out, and it's less than 1/3 circumference. What will you do?
See, since it is intraoperatively found out, one who is experienced lab surgeon can do an end-to-end sutures.
What do you mean end-to-end? There's only, there's a bile duct lateral injury, isn't it?
Okay.
You mean closure of the...
Yes.
Closure
with or without a T-tube might be helpful.
Yeah. Anyone in the panel wanting to do a hepaticojejunostomy for this kind of an injury?
No.
Yes, good. So that's a good message. So if it is a lateral injury, we are talking about a Strasberg D injury. It's just a lateral injury, no tissue loss, perfectly acceptable to just do a primary closure and come out. And it could be the same surgeon who's doing it, or it could be a surgeon more senior than him who has just come to help. But is that sufficient, Dr. Tarun?
I think
just closure,
intracorporeal
lateral
closure.
injury closure, is that sufficient?
Yes, I think it's sufficient.
It's sufficient.
Yes.
Are you happy with that, or?
Yes,
he may be right. It may be sufficient. He's going to put a drain and come out. If there's a leak, it's going to come out, and he will deal with it post-operatively by DRCP. But is there anything else you would do as a surgeon after doing that primary closure?
If it is a elective case clean cut with a sharp cold one, then suturing itself is sufficient. If it is an inflamed duct, we are doing in an acute setting, and if energy has been utilized and we are not sure, then I would like to put a stent, preferably not a tube, but internal stent.
Okay, so agreed. So the idea here is closure of the leak and then doing a maneuver. It could be anything. A maneuver to reduce the intrabiliary pressure. It could be a T-tube through the choledochotomy, or a T-tube above the choledochotomy or below the choledochotomy. So that's one thing. Or it could be a papillary stent which is passed from above, or it could be an ERCP and stenting. Dr. Anand, after this procedure, let's say somebody like Dr. Tarun is just happy with primary closure and a drain, but the patient has a leak, right? Would you want to go do an ERCP and stenting? What is your view about your ERCP and stenting versus a stent that is placed antegrade by the surgeon at the time of surgery?
If there is a leak, then ERCP is, we need to do a ERCP.
Right.
Even after closing the defect and placing external drain, if there is a leak, then we need to do an ERCP then.
Right. Okay, but if there is no leak,
if there is no
what
leak,
is the role of a prophylactic ERCP? That's what I'm trying to get at.
It is only to prevent.
Sorry to interrupt. Prophylactic meaning getting the endoscopist to do an ERCP anyway on day one, or in a setup where there is facilities for ERCP equipments to be transported to the operating room, doing the Strasberg D injury on-table suturing and getting the gastroenterologist to do an ERCP. I just want your view on these kind of...
Intra-op, we do it only to prevent biliary stricture, future biliary stricture. If we are doing an ERCP without any leak, it is only to prevent biliary stricture.
Okay. And in that scenario, what kind of a stent would it be? If your intention is to prevent future biliary stricture? You're talking about papillary stents, or you're talking about a long stent?
Papillary stents.
Yeah. Okay. You want to say something?
No. So the intention should be to reduce
10 more minutes. 4 minutes.
10 more minutes.
10 more minutes.
To reduce the transpapillary pressure gradient, so that there will be free flow of bile, rather than identify the injury and putting a stent.
Okay, fine. So the advice that needs to be given to the surgeon who's just done this operation is not to panic, seek help. As soon as the injury is recognized, get a specialist to come and help him, and if he's not, he should understand that the best long-term results happen when the experienced surgeon does it for the does it then and there in these kind of injuries. Last case, this lap chole was done for a chronic calculus cholecystitis. The callus, according to the surgeon, was dissected, but he says that the cystic duct was a bit wide and he required 2 clips along the breadth of it to complete the operation. No drain, patient sent home, comes to you a week later in peritonitis. Okay, LFT is deranged, 8.2 bilirubin, let's say conjugated was 6.5, alkaline phosphatase 1500, ALT, AST, all classic obstructive pattern. What would you do? Dr. Vadivel Kumar?
First thing is to stabilize the patient here, and then next to get an imaging in the form of MRCP, which is a much better option.
Great. So we will come to imaging in a minute, but I want to ask if any of the surgeons would want to consider re-laparoscopy in this patient.
This looks like a complete transection injury.
Yeah, and we are looking at 1 week post.
Yes.
Right.
So
any
imaging is the ideal way to go.
Any hands up for re-laparoscopy? No. Good, thank you. There's no indication for laparoscoping this patient, right? At this point in time, because it's 1 week, patient is in peritonitis. What you really want is imaging. Dr. Periyakarpan, MRCP or CT?
Your MRCP is much better. CT will not show the biliary anatomy. MRCP, which shows the biliary tract. In some cases, if you give a gadolinium contrast or something, you could demonstrate even the leak.
Okay, so so when would you want a CT? In a situation of bile duct injury.
In a situation of bile duct injury, if you suspect any vascular compromise or anything, or if you are suspecting any localized abscess.
So this particular patient, what would you do? MRCP or
MRCP.
You would do an MRCP. Yeah, so that's the MRCP.
It looks like that common hepatic duct is completely cut off.
So it's a complete transection, isn't it? Okay. So, a couple of things here. Number one, MRCP, CT, both are good in this scenario. 1 week post lap chole, they've got their advantages, unique advantages. MRCP is great because, as Dr. Periyakarpan said, it's fantastic to look at the biliary anatomy, gives you a good roadmap. But MRCP is not good in this particular scenario to tell you about vascular injuries. You have to understand, this is a complete biliary transection. What is the percentage of vascular injury in a case like this? What does the literature say?
20%, 15 to 20%.
Probably more. It's close to 50%. I mean, major bile duct injuries, when they present to the tertiary referral center, associated vascular injuries, the study from Lucknow, it's almost 50%, probably more, 50 to 60%. So one has to remember that, and for that reason, you have to bear in mind a CT. No harm doing both. When you
sometimes
have a serious.
The contrast increase CT with the MRCP, if you are able to do, okay. But more at this point, biliary drainage will be is the first important. So do a CT, see any collection in bilioma, drain that one, whether by percutance drainage or laparoscopy.
Right. So, Dr. Vadivel Kumaran, what would you do next?
So I think even any kind of drainage procedures is to be done, because patient has got a biliary peritonitis, we need to drain that thing. So I could have percutaneous drainage or a CT guided drainage, anything is fine.
Okay.
So stabilize the patient, take him out of the sepsis, and then do an MRCP. Based on MRCP findings, we can decide
So
upon
the idea is to get him out of sepsis. We all agree on that, right? We are not worried about where the injury is. We're not worried about reconstruction. We're not worried about anything really. He's in peritonitis, we want him safe, we want him out of peritonitis, and the way to do it is drain him out. External drainage, ultrasound guided, CT guided drainage of the peritoneal cavity, number one, that's or CT guided. Number two is PTBD, right? ERCP, is there any benefit in ERCP here?
I think there is a complete transaction, right? So there is no point in doing it.
No point in doing it. So I would go for a CT guided drainage of all the collections. 1 drain, 2 drain, 3 drains, doesn't matter. As many as is required, and a PTBD to get rid of the cholangitic sepsis. Surgery. What would be the ideal time to intervene? So remember, this patient had the operation 1 week ago, and she's come to you now. You've done all this. Let's say patient is stable. Would you operate? When would you operate? And what would you do for this patient? Just tell me the name of the operation. That's enough.
Roux-en-Y.
So this patient will require a Roux-en-Y hepaticojejunostomy reconstruction. There's absolutely no doubts about that. Anybody wants to think anything differently? So the operation is fine. But when will you do the operation? That's the
golden time is already lost. Which identified within few days or intraoperatively, then very well you could do it on table, seeking help. But having lost the golden time, you allow the ducts to dilate and go after a month or so.
Sorry?
After 6 weeks maybe.
Yeah, so the longer the better. 6 weeks is reasonably good time. That's what the literature also says. Have a look at that flow chart. So if it is a major bile duct injury, the one on the right, and if the patient comes within 72 hours, you're fine. I mean, if you have the expertise, if you're someone who does hepaticojejunostomies regularly, throughout the year, or hepaticojejunostomies as part of Whipples throughout the year, do it within 72 hours. But if that window period is gone, you're better off waiting till the sepsis is completely out of his body. It may take, the literature says 6 weeks, but it also says that the longer you wait, the better. So the idea is the patient should become completely sepsis free. So just to summarize, you need to consider where the location is. You need to know what kind of an injury it is, and always keep in mind that the goal of surgery is not just bringing a piece of jejunum and attaching it to the hepatic duct and saying that you've done the job. No, it is ensuring that the patient is free from cholangitic abscesses, peritoneal sepsis, and then wait, and then of course get the nutrition sorted out, and then put him on the list at a time when you think that your anastomosis is not going to fall apart, and that intestinal continuity is going to stay for the rest of the patient's life, and he doesn't have to come for redos and so on. So that's my last slide. So a few take-home messages. So it's a rare complication, thankfully. It used to be very common in the 90s, but it's now quite rare, but it's a preventable complication. As surgeons, we need to be very careful in our job, because one lap chole injury is sufficient to give years or decades of misery for the patient. So it's very, very important that we take absolute precautions when we do this operation. All these adjuncts, intraoperative cholangiogram, laparoscopic ultrasound, indocyanine green, everything that we discussed, they are only adjuncts. Please don't think that having these will make you a safer surgeon. Not at all. Adherence to safe principles of lap chole always remains the cornerstone. Adjuncts are adjuncts. You should be able to do it even without these adjuncts. That's what I tell my registrars. If you have to wait for a indocyanine green to come and guide you as to where the callous triangle is, it means you have not gone past the learning curve. You should be able to do it without any of those. Extremely important mentoring, and extremely important that one knows his or her limitations and asks for help, timely help. And do remember, when an injury occurs, the best repair is done by the experienced surgeon then and there. But if that is not available, always abandon the procedure, drain, and refer the patient to the appropriate center. So that brings to the end of my panel discussion. Thank you so much. Thank you so much for the audience for your patient listening. Thank you, panelists, Dr. Tarun, Dr. Loganathan, Dr. Saravanan, Dr. Anand, Dr. Periya Karuppan, and Dr. Vadivel Kumaran. Thank you very much. And thank you, chairpersons.
Thank you, sir. One basic doubt as a medical gastroenterologist. Do you recommend the placement of drainage tube for after every lap chole, or what is your opinion for the junior surgical G?
No.
The placement of drainage tube for a lap chole.
So, a drain placement after a routine lap chole is not in the standard teaching or not in any of the guidelines. It varies from surgeon to surgeon. Some surgeons have a very low threshold to placement of drain. It also depends on the setup in which they work. But generally speaking, I don't place drains unless I have a strong feeling that the patient is going to have an acute bleed in the first 24 hours, or I've done something like this. Thankfully,
The third case which had a broad cystic duct with 2 clips. Third case
Yeah.
you said.
Yeah.
So were in that case
These patients had drains. I mean, this one should have a drain because there was a difficulty. But easy ones, uncomplicated gallbladders, there is absolutely no indication for it. Now, in fact, the world is moving away from drains. Even after major resections, after robotic resections, sometimes we don't consider putting drain because the argument against the drain is it's not going to, if the patient is unwell, he will become unwell anyway, with drain or without drain. Yes, the drain may make you catch that thing a bit early, but the outcome is still going to be the same. So with lap choles, no, I hardly ever place drains.
Thank you. Any more? Okay, we'll wind up the section. Thank you, Dr. Jamil and the panelists. Thank you, sir, for a patient hearing.
Thank you, Dr. Jamil. Thank you all panelists. It's my esteemed duty to propose a vote of thanks. I thank all the panelists who have been part of the CME. I'll request a senior gastroenterologists who are in the audience to kindly felicitate all those participants who are not part of the Tamil Nadu ISG per se. I'll request Dr. Rajnikant to kindly felicitate Dr. Tarun Chitrambalam. Doctor, please. Fine. Dr. Tarun, please. Dr. Ratnaswamy to kindly come over and felicitate Dr. J. Loganathan, please. Dr. Loganathan, please. Please come over. Dr. Ganesh to felicitate Dr. Periya Karuppan, please. Request Dr. Badmanabhan to felicitate our moderator, Dr. J.K. Jamil, please. Thank you. Please. Thank you. I'll request all the panelists to just come over and have a first picture together. Meantime, are you ready? Hey, Karpan. Thank you so much, and it's a great pleasure for me to again thank thank the audiovisual people to put up this show, and also thank our pharma, Alcom, who have been generous enough to support this endeavor.